Hi, my name is Peter. I'm an emergency physician from Denmark, currently working in Stockholm, and today I want to talk with you about this subject of managing painful procedures in pediatric patients. And it could also have been called just procedural sedation of pediatrics. But I want to go a little bit broader, but not so broad that we're talking about the general like pain management of children, because that would be too wide a subject for this video. But I will specifically be talking about how do we manage the pain when the patient needs to have something done, whether it be a putting in a line, or taking vitals, or doing a painful procedure such as a reduction of a fracture, or like everything that we need to do on our pediatric patients in our emergency departments, and also talk about when it's not tangible to do a certain procedure in the emergency department and when we need to call for help. So that's the subject of today's talk. As always, I like to have a disclosure on our slides before we begin. I'm in no shape or form a pediatrician. I have done pediatrics as a junior in Denmark, emergency pediatrics, along with neonatology. I have just finished my rotation in Karolinska in Stockholm, in the pediatric hospital there called Astrid Lindgren's Children's Hospital. But I'm in no shape or form any expert in this, like in pediatrics or specifically in the procedural sedation of pediatric children or pediatrics. So, and I'm neither an expert in sedation. I have done videos on this, and I have done sedation in adults on rotations in anesthesia, but we are not doing sedation right now in adults. And part of what we are going to talk about today is how important like good sedation is, not only in children, but should be a mandate in adults as well. And when I say sedation, I also mean analgesia and sedation. So good pain management as well, right? And I think the reason why I'm doing this, even though I'm not an expert, is I think a lot of these things are not taught well for emergency physicians, because especially for pediatric sedation, there has always been other specialties owning this field, but like the subspecialties of orthopedics have done their thing when it comes to pediatrics. The subspecialties of surgery, abdominal surgery, children's abdominal surgery, and pediatric medicine has done their things, have done their own things when it comes to procedural sedation. But now, especially here in Scandinavia, now that we are becoming a bigger specialty, and we're taking over some of the children management, it's really important that we have a structured approach, and whether or not we treat children every day, or we're just going on to a rotation in emergency pediatric medicine and surgery, I hope this video will inform you somewhat on how to approach these patients and make you less anxious in the approach of relieving pain and anxiety in the children, and also maybe as an extrapolation in the adults that you meet. As always, when I have cases, they are made anonymous. The ages and details have been obscured, and the cases have been taken from different sources. So I will continue with the references and what we're going to be talking about today. Okay, so this talk is going to be first just going through the references so you can look it up yourself, all these things. Then I'll go into sedation and analgesia in in the pediatric population, and starting with non-pharmacology and then going on to pharmacology. And then in the end, I have a bunch of cases that we'll go through, and we can discuss how to approach these situations in our emergency departments with children. So the references I will be referencing here are mainly these two big guidelines in Sweden and in Denmark. One of them is this one, which is an excellent guideline made about pain in children, and it has a daughter guideline about sedation, which is on the next page. In Sweden, there is this great homepage called epet.se, which is a collaboration between, as I understand it, clinicians and pharmacologists in Karolinska, where they make this list for the entire population, or the entire Sweden, and you can look up all doses for all drugs almost that you use in children. And it's worth noticing that sometimes there's a significant mismatch or difference between the doses that you find in the EPAD and the doses that you find in other sources like FASS, which is the Swedish Promedicin, because FASS and it's Danish Promedicin daughter company is mainly informed by the product review, at least FASS is, and this is this is clinicians and pharmacologists going through the studies and weighing in pros and cons and so on. So when I worked in Karolinska in pediatric medicine and surgery, then this was mainly this was the main source. And if there was a huge discrepancy between the other sources and this, they always went with this. So I would also go with this in my clinical experience further on from this. Okay. Then there's a specific guideline for pain, like there's a Swedish version and here's a Danish version. Here's a Danish version and here's a Swedish version called Riktlinjer för smärtbehandling vid Astrid Lindgrens barnsjukhus. And then there's just one international guideline I've referenced here, which is the EM cases. Sorry, a podcast, not a guideline. For PSA, procedural sedation and analgesia, there's, as I talked about, this guideline, daughter guideline for the pain. Like the pain guideline has this daughter or sister guideline on procedure sedation, and is really good. There's lots of information besides the cookbook kind of write up in this book, so worth reading if you're going into your rotation. And Karolinska and the Swedish Organization for Pediatric Emergency Medicine, SWEPEM, recently also came out with this guideline, which is the Swedish version of the Danish thing. And as I will go into, these two guidelines look a lot alike, but there are differences. So you should use with the one that you locally are accepting, and use the local guidelines always, right? But it's nice to check up how things are being done in other places, and sometimes you'll notice that it's quite different actually. So we'll take a look on these differences as well during this video. There's a lot of other procedures, like other resources. I'll just mentioning a few here. One of them is this YouTube video on how to manage pre-procedure anxiety in children. And this is a really broad topic. I'll just list some areas which I'm not going into, but where I'll refer you to other links, my compassionate care lectures, because all pain and anxiety has something to do with compassionate care. I care deeply about this topic, and it's really important to have this with you. So check that out as well. For PSA, there are some great lectures on suites about procedural sedation. And if you want specifically information on regional blocks, Nusora on YouTube is a really good, which is one amongst many good resources. But this is something that we also used a lot in when I was during my rotation in anesthesia. So for fractures, we're going to talk about fractures because that's one of the main things that we're doing procedural sedation for in children. And this is not a lecture on how to manage the specific fractures, but I will mention the guidelines. And the guidelines I'm using is from Karolinska's Barnefrakturbok, and they have a guideline as well called Frakturer och luxation i öppenvården. There might be Danish similar guidelines, but I don't know of those. So please, again, use your local guidelines for this. Also, I have made orthopedic lectures on my channel for children, where you can see a bit, where you can go into a deeper dive into the specific fracture management of some of these things. And then I have listed the general pediatric resources. Don't forget the bubbles is great, and PEM, the Pediatric Emergency Medicine Playbook. EM Cases Pediatric section is great as well. SWEPEM has, like, the Swedish Pediatric Emergency Medicine Sub-Society is really good as well. And yeah, check out these if you're more interested in this area in general as pediatric pain management. We'll also be talking about a little bit about lacerations and wounds and how to manage those. And most of my, if not stated otherwise, the resources I'm referring to is from First 10 EM Laceration series, where he goes through all the evidence in this area. There was also a journal jam on this topic on EM cases, if you're interested. There's also this great homepage called Laceration Repair. If you haven't seen this before, you should definitely check that out, because it's everything laceration and wound care wise. And then there's I didn't list all of these references because there's lots of good laceration references out there, but as First 10 EM Justin Morganson will tell you, there's not a lot of evidence in this area. Lots of meaning, lots of opinion, but not a lot of evidence. So that's why I'm just sharing these three. And here are just small references to my own videos that I mentioned: compassionate care, the probabilistic approach to pediatric orthopedics, and EPALS, like the critically ill child. I also have some lectures on neonatal resuscitation, but that's beyond the scope of this lecture. And then in general, the airway series that I've done, I'll be talking a lot of, like, there's a lot of overlapping themes in this lecture from that. And here, in general, compassionate care and probabilistic thinking in headache, where I also go through a lot of the compassionate care techniques and how to approach adults, especially, or young adults as well, when we're talking about pediatrics. Okay, so let's head into the main lecture now. So before going into the specific management, pharmacological wise and non-pharmacological wise, we need to talk about what is the procedures that we need to be doing, and why are they necessary, and how can we like have a general approach to these. So just some procedures could be everything from doing vital signs to taking blood samples, to doing CT scans, to doing lumbar puncture, to doing more painful procedures, again, more painful procedures such as reductions of fractures. It could be like depending on what child you have in front of you, lots of, like, if you're a parent like I am, you will know that every small thing that is easy to do when they're not tired, it becomes exponentially more difficult when they're tired, or if the situation changes, or if your demeanor changes, and so on. So there are some patient factors when we're going into a procedure, when we need to think about how should we manage this procedure, pain wise. So one of the main things, or one of the really big things, is the developmental age of the child. So it's a very different thing whether you're doing a procedure in a small child, like a non-verbal child, an infant, whether versus a bigger child. There is a and this and it's always worth to consider whether they have some conditions or not, especially autism or ADHD is another one that's quite common, which may play into your choice and aggressiveness of the pain management. And when I'm saying this, like, to be clear, all children should get the optimal management, as most optimal management possible, so that they have the least amount of pain. But this is a complex decision. You need to. There's lots of moving parts. It's by definition a complex decision to how to manage a pain or anxiety in a child, because there's so many moving parts and so many factors. So when I'm talking about whether it's just be more or less aggressive, I mean that some children will need will need more drugs to get the procedure done than other children, like and sometimes in my opinion and in my experience, a condition like autism is something usually that makes things more complex because of their way of viewing the world, or seeing the world, or experiencing the world. Also, the situation is important here when we talk about patient factors. So, are there parents there? Are their parents coming, or are their parents not there? For instance, if it's an emergency, like a trauma or something like that, where their parents haven't reached them yet. Is it night or day? Meaning that are they tired or not? Have they waited for a long time? Are they hungry? Are they tired? Do you have an alliance with the parents? So on. So there's a lot of situational factors that, even though you're a cool, maybe 8-year-old child who usually can manage pain, well, if he or she is hungry and has a long day, then your tactic might be a totally different one, and more aggressive one, right? So then you have the conditions. So some conditions are emergent, like an emergency, and oftentimes you don't have time to do a perfect PSA on them. There's no time, or it's too dangerous. Just like in adults, if you do use too much sedation, then they might lose ABC stability. And then oftentimes, and that's also a bad sign, as we talked about in other lectures, if a child has an emergency condition, then usually you will be able to do more to them. And that's a red flag that they're in a really bad condition, that they don't care, or they care less if you prick them with a needle. And that's always that's a bad sign. But most of the things that almost all of the things that we're talking about today will be non-emergent conditions. But if you're in an emergency, you will need to put in that IV line without them having EMLA. You will need to put in. You will need to do the lumbar puncture without them sometimes having optimal sedation, and so on. Is it painful or not is important also about the condition, right? So certain conditions are inherently painful, others are not. But again, others may be anxiety provoking, either through the child, either through the parent who might have had experience with this and inadvertently made their child scared, or some other factors, right? So, but the main thing here is it painful? Because painful procedures needs pain medication, as opposed to things that are just sort of scary things, or things where you have to lie still, like a CT scan. Usually doesn't need any pain medication, but there's a need for you the patient to lie still, right? So different conditions need different approaches. And then there's some conditions where there's a discussion internationally whether we should do something with pain medication or not. And now I'm going to the adult world, but there might be a pediatric example as well that I can't come up with right now. So an adult example would be if you're doing a atrial fibrillation conversion. Then in Scandinavia, there's a tradition to not use pain medication here because there's different arguments for this. But whatever the arguments are, the patient, even though they might say "ow" when the shock is being delivered, they will not remember it afterwards. So in my experience, most anesthesiologists in Scandinavia do not use pain medication for this, and it's probably okay. But there's a debate, right? And in North America, they will use it, but there's a risk. And then we know that mixing a sedation agent with something with pain medication, there is a higher risk of them getting a complication like a lost airway and so on. It's a minimal risk, but that's why there's a debate, right? So some procedures we may not be in agreement of whether or not they're painful or not. Now I just came up with a pediatric example. And a pediatric example would be Justin Morgenstern have talked about lumbar punctures or any painful procedures in small infants. And there used to be a paradigm that said that the infants don't feel pain, which has been debunked, right? And Justin Morgenstern talks about sugar water, whether that is a pain management or whether that's just sedation. And you can go check his blog or SMAC podcast, a SMAC video out on this topic. But this is also an area where there is some controversy whether or not some of the drugs actually has both pain and sedation properties, or whether they're just one or the other, and whether the procedure is whether they need pain medication or just can get sucrose for instance lumbar puncture. Then there's also something about the duration of the procedure. So if the procedure is really long, you will need a different tactic, right? And things something I forgot to write up was, of course, the complexity of the procedure. So if you have a wound in your face, even though it might be a quick fix potentially, it might be so complex that it's nothing that we can do in the emergency department. So you need to either postpone the procedure or call a specialist in the hospital to actually do the procedure, and then it usually has to be done in the OR. And these things are some of the factors for conditions. Then you have team factors as well. The experience in sedation by the team. You might not have a team who are experienced in nitrous oxide. You might not have a team who are experienced in procedural sedation at all, like Dextor or any of the other drugs that we'll talk about. And then you have to use another tactic, right? Also, the calming demeanor is there's a saying that a calming demeanor is like 2 milligrams of midazolam or something like that. It's really important, and you'll know that when you do your when you're going to, if you ever do intubations or sedations on a patient, it's really important to have a calming demeanor, because then the patient will have less of an adrenaline spike. They will be easier to sedate, everything is much better. It is also part of the compassionate care, but not. But there's a like, and here is one of the examples of how and why this is so important to be able to encourage, like, or induce an alliance with your patient and make them calm, which is easier said than done in most children because they're scared. All right, so. And then it's always worth thinking, well, can we do nothing? And when I mean nothing, I kind of mean non-pharmacological approaches. And those we should always implement. Always. These are always part of our tactic, right? These should be a reflex for us. And we'll talk about which which ones they are. And then we should always also think about, is this procedure necessary? Is there another way? So could we, instead of doing venous blood samples, maybe do capillary ones? Could we, instead of closing this wound with a suture, maybe close it with glue? And so on. Like there's usually different approaches, different ways, and we need to weigh this in our approach, right? Is it really busy right now? Is the time running out on the time window and when we can do the procedure? There's like all of these things makes this area really interesting, but also highly complex. There's so many moving parts. So that's why I wanted to make this video and just go through some of my thoughts on this and how I was taught, not fully, but how I've been taught doing this. And I might, as I said, I might not be perfect at this. So please comment if there are anything that you would do differently, or anything that's outright wrong, and I would gladly hear it. So thanks. And let's move into the non-pharmacological part of this. So one of the like, we built our non-pharmacological approach on compassionate care. If you don't know what that is, please check out my video on this topic, or my blog series, or any of the other really great lectures on this this really important area. But in short, compassionate care is the idea that we should approach our patients with empathy, but not full empathy, but instead using half a step back from full empathy, which would be empathy plus a intention to get them to the next step, or treat them, or do something about their condition. And this might seem basic, but there's lots of nuances to it, right? And just some of the things I've noticed mentioned here is like validation, validating that validation, right? Mentioning that they have like listening to our patients, and showing them that we are listening, and by either verbally saying so, or non-verbally doing so. And there's lots of really different, like I could have made many more bubbles here, but please check out my other video for the details on this important topic here. Okay, so this lecture I'm basing on the recommendations from both the Swedish and the Danish guidelines on this. And most of the time they are in agreement. So you'll see that on the non-pharmacological part, they are almost entirely in agreement, and almost it seems like the authors have looked towards across the water, and kind of looked on each other's work, or maybe referencing a common reference, but because they're writing kind of the same thing. So there are some overarching things that are important, they both think. So good pain reduction, PSA and other, in children takes time. It is with children a condition and cannot be negotiated, right? So this is something that, like, this is really important. So it's not a bother, it's not a problem the system should be built like taking into account that emergency management of patients, of children, takes time, and everything should be revolving around that fact. It shouldn't be a bother that, oh, this patient probably suddenly needs more medication or suddenly needs much other a totally different approach that we have planned for. That is how children work. Okay, so we should build our departments around this fact, not try to not be annoyed when when we need to change plans or because that is something that we could have foreseen. Restraining children should be avoided, and I definitely agree with this. There are certain emergencies where we may need to restrain children for a short while to be able to do it, or there are certain really short procedures where it's more bothersome, I believe, to keep trying to give drugs which are not working and just getting it done. Like you could build up a lot of have a huge plan for something that takes a few seconds just to do a quick painful procedure on. So it depends on your resources, the situation, and the flow and everything, but always taking into account that it takes time and it's all right. But sometimes I believe that some of the painful procedures, if they can be done really quickly, like in a few seconds, it's okay to restrain for for a little while. And we're doing this when we restrain children when we have to look into their mouths or into their ears and so on. So things like that. Okay. But this is I'm sure there are opinions on this topic, and I'm glad to hear them. Individualize your approach to the child, personality, social age, and so on. And we've already been through this. That is exactly what we just been through, right? And involve the parents and the child, and it should be age appropriate. And then they go into the non-pharmacological things that they agree on here. Use non-pharmacological aspects always, yeah, and respect empathy and anxiety reducing approach, yes. And then with pharmacological, in the pharmacological department, they think have a plan A, B, and C. Do a timeout, and if the plan A doesn't seem to work, then do a timeout. I would usually say do a timeout before with your team before you're doing a big procedure, and then do a regroup during the procedure if plan A is not working, right? And you have to make the team psychologically safe so that they can go in and say, oh, this is not working, and then take a step back. Okay, then be prepared for PSA complications. So I won't go into details about the PSA complications, but you could, like, the most of them are ABC instability, right? So, and they're usually drug specific. There are some drug specific ones, and there are some drug unspecific ones. Like losing the airway with sedation is one of the drug non-specific ones. Bradycardia in Dextor, Dextor. Is another one, but that is drug specific, right? So the different ones have different problems or side effects, and we'll go into a little bit of those as well, but not too much. And then I just wanted to throw out there our non-pharmacological approach, and in general our approach to children should probably be much more adapted to our adult emergency departments as well, because we oftentimes ignore the stress in adults. I've talked a lot about this, and Justin Morgenstern has as well, so I won't go into details here, but just saying, consider whether the approach that we're going through in children now could be applied to adults, at least some of it, and in some ways or shape or form. Okay. Okay, so approaching the sick child in general, we're still talking about the non-pharmacological approach to the child, getting their alliance and getting them comfortable, right? And there's lots of books on this and lots of videos on this, and I'll just share my approach from my experience, which partly is from the theory of it, partly experience, right? So you don't need to do the things that I'm saying here. You might have your own approach, but through my experience in pediatric medicine and surgery, through my career, I've picked up these. So first of all, is a child sick or not sick? If they're not sick, then you have the time to do this. If they are sick, you do still have time to do some of this, but not all of it. Compassionate care goes for both sick and not sick, right? But the sick child, as we talked about in the EPALS lecture, you can see whether they have body color, breathing, or breathing body color, and behavior, right? So it's kind of like an ABC, or the pediatric assessment triangle in APLS. So this is what we are going, like, just checking from the door, are they in a bad way or not? But you still have, even if they're in a bad way, have compassion with the child and with their caretaker, because that will calm down things as well, and have but also just from a human perspective. So it never takes too long to just take their hand and say that you're here, and you will be going through an ABC now, but you're here to take questions afterwards and so on. It doesn't take a long time to do compassionate care. Okay, then I also think about, like, are they warming up to me from the beginning or not? I usually have different pediatric emergency physicians and different pediatricians have different approaches to this. I usually, on the spectrum of playful or clownish to non-playful, and very seriously, or very, very clinically professional but serious, I probably are more towards the clowny kind of approach. I like to go around and just play around in the department, and when I see a child that might not be one of my patients, I will play with them as well, sometimes in the corridor, because I think not only in adults emergency medicine, but also in especially in children's emergency medicine, when you're just walking around the department, people are seeing us, even though they might not be our patients. We are contributing to the culture and the experience of everyone. So if we are muttering or shouting or being angry, or that might not have anything to do with our patient, but other patients in the department sees this, and the entire culture and atmosphere of the place is changed because of this. Maybe not just because of one thing, but your entire demeanor is important here. Okay. And for that's just one specific thing. But when we then go to our patient, if we talk about the specific patient that is ours, then we might enter the room in a playful way. Maybe not. It depends on the situation. Whether it's a serious situation where it's an emergency or not. But oftentimes I will try to be a little bit playful to just get a temperature of the child's, get a temperature of the room, and see whether I can, and if they buy it, then I can follow along that path. And oftentimes the child is not warming up. They are not, usually, because they're either sick, or it's a new situation for them, or their parents or they themselves are anxious. So it's perfectly normal to not warm up. Okay, and if they're not warming up despite my efforts in the beginning, then I'll back off. Then I'll talk to the parent, and when I'm talking to the parent, then the child has time to look at me, and I might, if the child is looking at me and maybe trying to gauge who I am, then depending on the age, I will maybe do a small playful thing with them, maybe do a peekaboo or something while I'm talking to the parent, to show them that I'm not dangerous. And I will also use the nonverbal language, the paraverbal and the nonverbal, like getting down, using a calm tone, and yeah. I'm sure you have been in the same situation. I think you know what I mean. But that's kind of like, are they warming up or not? And if they're not, then I'll talk to the parents first. If they are warming up, then I'll talk a little bit with the child, play a little bit, and then I'll go to the parents afterwards, if the parents are the ones with the information. So usually with the younger children. If it's a young adults, like if it's a teenager, the same approach. Sometimes the teenager don't want to talk with you. Sometimes, but sometimes I need the parent out. Oftentimes I need the parent out of the room. At least at one point during the conversation with the teenager, I will take the parent out of the room to discuss some things like drugs or sex and so on. But yeah, it's important to have these, like, are they warming up or not? And if they're not, then back off, talk to the other person in the room, and yeah. Then come prepared. I have, like, how many times I've saved, like, my examination have been saved by bubbles, or for instance, like a play toy that I'm using right now, like these small LED lights from Lego. Because I will, depending on the age of the child, I will usually lay out. I don't have one approach to, like, it depends on the situation, but one approach I do use is use a layout like a stethoscope, this light, maybe a reflex hammer and so on, and then an otoscope as well, and then they can choose which one do you want to be examined with first, and then they usually pick one of them, and then it becomes a game, a playful thing, right? And I think I enjoy that, and I usually and then I praise them when it's important to, like, keep praising them and saying if they're doing good things, then they should be praised, right? Because usually it's a hard situation for them, and yeah, so that's usually how I will do it. And the way I use this sometimes is like, oh, can you try to push on the stomach? Then you'll see it lights up, and when it lights up, then please can you help me? Not just like I'll give them a task. Can you help me light where I need to examine you? So I usually do it for the examination of the stomach, where they have to be distracted. Please light the stomach, light up my stomach, and I'll talk to them while I'm pushing on their stomach, right? To ask how's going in school, to try to distract them and so on. Yeah. And be playful. We talked about it. You don't have to be it. I think I have seen many really, really good doctors in emergency pediatrics that are not playful. You don't have to be. I as I said, I'm on the spectrum towards the more clowny kind of way, but you don't have to be that way. It's much more important that you are yourself, I think, and that you have your own approach. And I do think that a too clowny approach can sometimes be a problem for me as well. So I'm somewhere in the middle and towards the clowny approach, right? But I think it's important to like also be professional when you're outside of the patient's rooms. Don't talk bad about your patients or the parents. Be professional, and if there are concern about any things, then do talk professionally about them. And play in the corridor between patients as part of the same thing. And then the exam should be opportunistic, right? So if the child is like, if I'm laying out all of my stuff, right, all of my examination tools, and then I will tell the patient, well, if they choose the more painful procedures first, like the otoscope or the looking into the mouth, then I might try to steer them away from that if they're a small child and they haven't done it before. But if they're not, then I'll do it. So depending on what the child wants and what they feel like. But in general teachings, it's good to listen to the chest when they're not screaming, which is oftentimes in the beginning, especially with small children. Look in the ears in the end, because that is where this usually what hurts, right? And when you're looking into the mouth, then I usually try to have a spatula and point it, like if they really don't want to be examined and I need to check in, then I need to examine them. Then I will put the spatula right into the oropharynx, so they have a gag reflex. Then I'll have 1 second to see. So, but most times you can play your way into the exams, but there might come some time during the examination where you can't, like, you've tried all your resources, and you still need to do that ear exam. Then you have to then the child sits on their lap of their caretaker, and then you will look into the ears with force, or with restraining them a little bit, and that's what I mean. Like sometimes things need to be done like that, but you have tried the other approach first. And oftentimes I will show and tell, and sometimes it depends on the situation. But if the child is warming up, I will do more of a show and tell sometimes, where do you want to try? Like they can try their stethoscope. They can show me where the heart is. They can show me. They can put on, like, I will give them tasks so they can put on the light, and so on. Like I will be bewildered or wondered with them in this experience, and then it becomes a game, right? But sometimes you do need to be more fast and effective, especially if they're tired and hungry and not warming up. Then you move more towards the latter one, maybe. And usually, if they're really sick, then that's what has to be done. And then choice. It's good to make choices for children, but not things. Don't let it be a choice whether or not they are examined, because they have some things they just have to do. So don't ask, do you want? Can I examine your ears? But say instead, like, we're going to examine your ears. Do you want to sit in your parents' lap or not? So something like they can choose from things that are not important, but some things we need to do, and then you have to say it, that you have to, and phrase it in that way. But I will say that sometimes I have I have a habit of asking them anyway, and if I phrase it wrong, then I'll just, oh, sorry, I mean, can I examine your ears? And if I catch myself saying that, I'll say, oh, sorry, yeah, we need to examine your ears instead of making it a question. Yeah, and then involve the child age appropriately. And so on. And we talked about that already as well. So that's my approach, and just some tips and tricks and some nuances. And there's lots of other nuances depending on the situation, but that's just how I. And underlying all of this is the compassionate care kind of way of being with patients, and a listening and non-verbal, like active listening and non-verbal way of doing it. So down, like I like to sit, I like to like crouch down, be on the child's height, and then not too close to them in the beginning, and then moving closer and closer. I might be hiding behind the counter and speaking with them there. If they are really intimidated, I'll make myself small so that they don't have to be scared. And I usually have my beard always, and I'm a tall guy, and I have a deep voice, and I have a beard. A lot of the things, like I've never had much problems with the children when I'm like, there's no difference between whether or not I have beard. So look how you want, I think, for like, at least for the most part, as long as it's professional, and just be yourself, but try to take some into account these tips that I mentioned here. Okay, and these guidelines that I mentioned also have these tips for how to, like, verbally, how to speak with the child during medical procedures. And I mean, I might, in general, it's a lot about distraction and positive information instead of using negatively focused language. I don't worry too much about this. I think there's definitely some pearls in doing mostly this, and training mostly this on the positive side, on the green side. But I don't think, like, saying one of these things is okay. That would be okay in a situation anyway. You will feel like it's more important to be in the situation, I think, and then you can practice some phrases, but be in the situation and notice when what you're saying is not going the right way, right? Then you know that for next time, maybe not use that phrase. In general, I would just say, don't lie to the child. If something is going to hurt, they usually ask, is this going to hurt? Yes, this will hurt, but it's and there might be some information here where you can say it in a better way, but I usually say, like, this is going to hurt, and minimize the time from when you give the information that this is going to hurt to when you do the procedure. There's more tips on the Stimulus podcast episode 22 on this. But I just don't lie to the child, because you will lose your alliance with them if you lie and it turns out that it hurts. Also, like, is this going to be, another question is oftentimes, is this going to be painful? And I will say, well, it's going to be painful when I will, like, in the beginning it is going to be painful, but afterwards you will not feel a thing, right? Or you will, and if you do feel something, we will give you more analgesia. So the most painful part is the beginning, where when we'll sit, like when we'll do local anesthesia, and then afterwards you will not feel a thing, and if you do, you will get more. So depending phrasing it depending on the age of the child, right? So exactly. Before the procedures, if there's a planned procedure, or if there's a bit of time between them coming in and you knowing what kind of procedure is going to be done before you collect your team and so on, you could, in Sweden at least, use this MediPrep. I don't know if there's a Danish one. There should be, but I don't think there is. But MediPrep.se, they have all procedures for children, so that you can give this to the parents when they go home, and if they're doing a lumbar puncture tomorrow, or if they're doing a reduction of a fracture tomorrow, then they can see how it's going to be done. Because usually, I think the philosophy here is that the enemy, that is usually less intimidating than the unknown enemy. So even though you do know that you're going to have something hurtful being done the next day, at least you know what it is, and you know the steps, and but it's a good idea to just watch the video yourself before you give it to the patients, so that you know that it is the same that they're going to do. And also, and this is just another thing, same thing. Like, I think in Pro Medicine in Denmark, there's an instruction video as well. This is just medical instructions for patients, for any kind of medication. So, for instance, if you're giving them EMLA, this Band-Aid, to reduce pain in when you're doing a procedure, like giving a art line or a arterial line, or a lumbar puncture, or doing a peripheral venous catheter, then you will then they can see that at home, how to apply it. Okay, that was just really short on the non-pharmacological part, or really short, 30 minutes. But we'll move into the pharmacological department now. So all of this that I just talked about, this is something that has to be done every time. Like, every time. This is your general approach. This is the bread and butter of your approach to your PSA patient. Okay, so, but then you have to consider, okay, oftentimes this is not enough. If I have a broken something and you have to reduce it, then you have to get another approach. Sometimes it is enough. If you do, like, doing a peripheral venous catheter in a older child, like a 13 or 14-year-old child who is cool and not anxious about it, and the parents are cool and not anxious about it, and it's the middle of the day and they've done it before and so on, then usually they don't need anything else. But even an adult, like 28-year-old adults, might be really scared of needles, right? So they're like different approaches, different ways, but you always have to consider it. Okay, moving into pharma. And here I'm going into the two guidelines, the Danish and the Swedish one, and we'll have them side by side so you can see that they're their different approaches, or really similar approaches. Just by looking at the front page, you can see one of the differences between the two healthcare systems. This, the Danish one, is made with collaboration from lots of different societies. The Danish Society of Anesthesia, the nurses like Dana, the nurses emergency, like the emergency nursing group, DASEM, the Danish Emergency Medicine Society, like the Danish Society of Emergency Medicine, the Knowledge Center of Children Pain in probably Rigshospitalet, and so on, right? These Danish Society of Almen Medicin, like Vårdcentral, family medicine, and so on. And here, this is an excellent product, but it's from Karolinska, and this is made by people from Karolinska, and and each hospital has their own one of these, right? Or at least they're using this, but there's no societies are not in the same way coming together and doing collaborative guidelines in Sweden. There's lots of problems with this. So each hospital usually have their own guideline, which are really great. But it's a lot of wasted work, I think, for a lot of people where they could just take this guideline to this hospital, and then you can do local, small tweaks if you want. But here they do the entire guideline locally, and then they don't do the tweaks. And there is no, if you move from one hospital to the other, you have to read this 200-page book, and you, being a patient in different hospitals, you will come across different approaches. So there's a high variability in Sweden for that reason. Maybe not necessarily in this area, but in other areas in general. All right, so that's my 2 cents on the different systems. I've made an entire video on this as well, an entire blog on the differences between Sweden and Denmark. So if you have any other concerns on that, you can check those out. All right, but that's enough of that. These two are excellent products, both of them. So just show that this general approach, the key points are exactly the same, almost word by word here. And once you go into the book, you'll see a stepwise approach as well, where you have in the Swedish one a plan A, a plan B, a plan C, and then you have tips and tricks down here. You have the duration and so on. And in the Danish one, you have this plan A, plan B, plan C down here. And you even have a flow chart in the bottom. You also have some of the, here are tips and tricks, duration, and so on. So in a lot of ways, they're totally they're really much the same as when you talk about build up. What the Swedish doesn't have, but what the Danish have, is a theoretical part. So the Swedish one is mainly just, I have a fracture. What kind of sedation and analgesia is appropriate for this? Where the Danish one has, this is more like a document where you can also read the theory behind a lot of the things. So you can become knowledgeable about the area of procedural sedation in children. Okay, so what kind of areas are they covering? Well, in Sweden, it's fractures, luxations, and so on. It's casts, it's lumbar puncture, it's wounds, it's burn wounds or burns. It's foreign body, subcutaneous ones. It's hernias. It's invagination or intussusception, right? It's radiology and so on. And then there's an index of medication. And in Denmark, it's actually there are some some specific procedures as well, right? So there's suturing, which is the same. There's burns, which is the same. Foreign body, which is the same. They have blood samples and PVK, which is a good thing because this is not in the procedure book here, but it should probably be. And they also have some specific ones for orthopedic, removing of these threads that you put into fractures, and so on. But by and large, it's the same topic material, right? They don't have reductions here though in Denmark, and I haven't worked in Denmark for 5 or 6 years now, so I'm not sure whether it's because they don't reduce in the emergency departments or not. I will have to look that up, but it seems to me that that part is a big thing that is left out here, but it's in the Swedish ones. Okay, so if we go into some of the specific plans for specific procedures, just side by side, just comparing the two countries here. Lumbar puncture, if stable and clinically, like the clinically stable condition, lumbar puncture, and then the lumbar puncture here. Then they will say here, it takes 15 minutes. It takes 15 minutes, yes. Is there pain? Yes. And if we go into the plan, then they will say that here you need to H adequate explanation. You'll use EMLA, and you'll do positioning, and then maybe sugar water for small children. And this is a general difference as well. In the Swedish approach, they will use paracetamol almost always as a base layer of pain medication, or NSAIDs, or both, right? In this case, of course, because of this is a puncture, they are very afraid of the NSAID potentially making patient bleed a little bit more. Therefore, they will want to give it in lumbar puncture. I'm not sure whether that is a general, a legitimate concern, but I theoretically I agree. Then they will also say do EMLA, which was the same thing as well. And then they specify how long time it takes, how long time they should use before you can do it. 1 hour usually, EMLAs. And usually 1 to 2 hours before the procedure of paracetamol and so on. And then they will also say glucose here. And they another difference here is that in the Swedish one, and this may be because this is made for for Karolinska, and the Danish one is a general one made for all hospitals and all emergency departments in Denmark. There's this is a tertiary hospital, so they are closer to they're closer to experts in area management maybe, and they may feel that Dextor and Demodetin, I would just call it Dextor because it's easier, Dextor and ketamine is part of the plan A for certain children, right? Which is part of the plan C, I think, down here. Ketamine here, yeah, Parol, ketamine, and Dextor. So the drugs are the same, but in general, most of the Swedish guidelines, they will use Dextor and ketamine and other like midazolam, intranasal fentanyl. They'll use those more often as a plan A. The reason why I cannot be sure of. And in here, in Denmark, they're not so keen on doing that. And part of it, I will say, part of it is it may be the fact that this is a local tertiary hospital, and this is also it is made in a tertiary hospital, but it's also this is part of the SWE-PEM, it is a general guideline. So it might be because in Denmark we have been kind of afraid up till now of sedation, and sedation may not. In Sweden, it's very much hospital specific whether they have come a long way in sedation or not. So there might be different reasons for it. What is essential though is that it should be the best plan for the patient in the situation, and whether ketamine should be here or whether it should be down here, I cannot say. But just something to think about. And it's interesting to see that there are some cultural differences here, and probably because of the history of emergency medicine as a specialty more so than a lot of other more scientific things. Okay, taking one more of these guidelines, just comparing them. So let's see here. This is a wound, so sårskada, and you have to suture a wound. And we know that suture of wounds are different in different locations and so on. But let's just point out some things here. Lots of the same things here. Consider general anesthesia if it's a really big wound and so on. Says the same here. in the Swedish one. But then here, överväg grundläggande smärtlindring med paracetamol och ibuprofen. Again, it's not mentioned here in the Danish one, but use ibuprofen or paracetamol as a base, right? Then, if there's anxiety, use midazolam or Lustgas, nitric oxide, not nitrous oxide, and that's the same as well, right? But combination here, they will also mention, again, they're using more advanced drugs earlier on in the planning. Use nasal Dextor or ketamine, maybe a combination of them, because up here, exactly, maybe a combination of them. So there are certainly differences, but as a rule of thumb, the Swedish guidelines will usually more often use ketamine or Dextor earlier on in their planning, and will almost always use paracetamol or ibuprofen as a base. But other than that, the guidelines are quite similar. Okay, so let's go into these drugs. What kind of drugs can we use? And when I'll do a really basic overview so that you can use it when you so we can use it for the cases later on. But I will do this disclaimer that as with all sedation, it's dose dependent. Like if you use a high dose or a low dose, and like for instance with ketamine or Dextor, you have especially with ketamine, you will have totally different low dose will be pain dose ketamine, right? Then you have dissociative dose or subdissociative dose, and so on. So it depends. So doses are important, and also how fast you give the doses, right? And in what environment. So if we use ketamine as an example again, if you use an infusion as opposed to a push dose, you will get more side effects with the push dose as opposed to the infusion. And a slow infusion is better than a slow is better than a fast infusion for side effects, and so on, right? So dose is important when it comes to sedation, and from the lectures on airway management and physiologically difficult airway management, like with a patient who has hypotension or hypoxia. If you use a normal dose of sedation, there they will lose their blood pressure, even if it's ketamine, right? Because they're all adrenaline. Adrenaline is the only thing keeping their blood pressure up. So dose is so important when it comes to these things. Then also, we're not taking into account combination of drugs. Oftentimes, we do combine certain drugs, and I'll go into which drugs can and cannot be combined here in sedation of children. And infusion time we talked about, like side effects and administration. Is this going to be an intranasal, or is this going to be an IV or an IM? Intranasal, there is you can only push 1 milliliter at a time. The intranasal route is usually a bit it can be blocked in children, right, and adults, but especially in children. And the administration of it can be somewhat invariable if or the absorption might be a little bit invariable. So they might get some of the dose in the beginning and then some of the dose after 15 minutes when they snort a little bit more up, and so on. So sometimes it's a little bit less predictable, the intranasal route, but in my experience, it's usually quite good with both fentanyl and Dextor and ketamine. But you can only push 1 milliliter of the drug per nostril, right? Otherwise, it'll just run out and you don't know what dose you're giving. So that's usually for the smaller children, especially for ketamine, and Dextor has a more potent more potent concentration, so it can be used for a little bit bigger children as well. And then of course, talking about all of this, some of it has to be done in general anesthesia in the OR setting. And then I'll show which ones are anxiolytic as well and which ones are local. And this is just quick overview. There might be some drugs that are anxiolytic that I'm not showing, and so on. So there might be academic. This is not a complete list, and it is not totally right, but it's good enough to use clinically. So in general, we might think of the drugs as being either with or without analgesia, like it can reduce pain or it cannot, and with or without sedation, right? So there is some drug, like this is an area where we know there is no drugs we're going to use for this specific area here, because if there's no sedation and no pain reduction, then we don't use those drugs. The first drugs we're going to talk about is no sedation but analgesia, and you have EMLA, which is a good it's like it's a band or is like a local xylocaine kind of compound for putting in IV lines for which you put on the skin 1 hour before, and it can only be on the skin for maybe 4 or 5 hours, I think. So you have to remove it afterwards and remember to remove it afterwards, which is often not remembered. So something or it's often forgotten, right? But then the parents will just remove it at home. So that's EMLA. It's a mild, so that's why I'm using it here. It's mildly analgesic, right? And you have paracetamol and NSAID, and there's a confidence interval depending on which dose you're using, right? So paracetamol, as we'll go into, have different doses and different dose ranges. At least how we use it in Sweden, but I haven't heard, not in Denmark. But all right, then you have lat gel, and lat gel, and there's no space here, but there's no sedation in it. It's just analgesic. And this is where EMLA is when there's no hole in the skin. Lat gel is when there is a hole in the skin, and it can go into the crevasses and sedate there. And you have local xylocaine, and there is some mixed evidence whether buffered xylocaine actually works, but where I worked, we used buffered. So you buffer it. I think it's a ratio of 1 to 10 sodium bicarbonate. And also you can use regional blockade. These are the things that they give pain relief, and they can give really strong pain relief for like with xylocaine, like a finger block or a regional blockade with ultrasound led like a femoral block or a axial block. You can reduce an arm in that kind of analgesic. Yeah, and you can suture a wound without anything else with these as well, oftentimes. So these are quite strong on this end and for procedures. Then you have the analgesia where there's also sedation, and it can be argued where they fit all of these, and it's really dose dependent and so on. But what we use are usually morphine. Morphine, like intravenous morphine or peroral morphine, is usually only reserved for specific conditions, like when paracetamol, NSAID, and clonidine is not effective enough, or in bigger children. But what we do use a lot is intranasal fentanyl, especially for burn wounds. It's also something that we use in my adult hospital. If any child comes in with a very painful thing, because we're a big city hospital, we oftentimes get people running in with their children in a painful condition, whether or not emergency or not. But we'll usually kind of pain relieve them and then send them to the hospital. We'll get them paracetamol or NSAIDs if they're big enough to get that, with adult doses, because we don't have the children's doses always, and then give them intranasal fentanyl through a syringe, through a dispenser, which I'll show you. And they also have somewhat, like with morphine, of course, we know that you can sedate someone with morphine, especially the L-fentanyl and other kind of really quick morphines and so on. So morphine can be anywhere depending on what kind of morphine it is. Clonidine also can be very sedative as well, but it's mainly like a blood pressure medication that also has analgesic and sedative properties that we are using a lot in children. And then you have ketamine as well, which also has these properties, right? And IV more so than IM, and usually it's a dose thing as well. You can, Then you have the ones, this is important, right, where there's no analgesia, but they're sedation. So Dextor, and I can never pronounce this, but dexmedetomidine or Dextor. So Dextor induces usually said that Dextor induces a natural sleep. We use it a lot in the like intermediate both intensive but also intermediate the medical departments in my hospital where we sedate patients to accept certain things such as a BiPAP. But in children we use it a lot for both painful and non-painful procedures. But if you use it for painful procedures, you need to combine it with something with analgesic properties, right? Because otherwise they will just wake up. But it's really good for CT scans. It's really good if the patient is moving around, right? So the painful, you can still be scared if you give them paracetamol and say they might not have pain, but they'll still be scared. So that or they might still move around. So especially for small children when you're suturing and they need to not move around, that's when you can give them Dextor or maybe iron ketamine as well. It works the same way. Then you have virtual reality and midazolam, and these have anxiolytic properties as well. Dextor doesn't, as far as I know, they don't have anxiolytic properties. That's why if you prick them and they haven't been if you're suturing them in Dextor, when they feel pain they will wake up. So but virtual reality is a really strong tool to be using because it's not sedative. They don't fall asleep, but they are distracted, right? And they can be it's like hypnosis. I didn't bring hypnosis in because I haven't used hypnosis that much myself, but the magic glove and other hypnosis techniques can be used. And virtual reality, I guess, goes into that kind of category. And we reduce fractures in virtual reality. And so on. So it's a really good tool as well. Midazolam as well, really good tool. And we'll talk about suturing alternatives if you don't have lat gel, because oftentimes you don't. Because it's not stocked, or that's the most common reason. And then you can sometimes use midazolam combined with EMLA combined with local silocaine instead for a lot of wounds, especially in a little bit bigger children. Midazolam is also really good in autistic children for being anxiolytic and sedative, right? And also in reducing certain things is like a hernia is really good. So, and then sugar water. I will place this resource from First 10 EM, whether it's analgesic or placebo. I'll placing it here in the middle, but probably it's, if you follow the argument of Justin Morgenstern, it's more to the non-analgesic side, and it's just sedation. So for small children, also for infants, we should probably, for painful procedures, give them pain medication as well, along with the sugar. Okay. And then you have nitrous oxide, which is, we use it interchangeably almost with virtual reality, depending on the age of the child. So with nitrous oxide, though, you need a child that you can communicate with in a language, either English or like Swedish Danish, right? And you need trained personnel for both of these to guide the patient through them. All right, so doses, and I'll just go through it. You can read yourself in the guidelines, but the doses I'll just quickly go through so you kind of know what we are doing in Sweden, and then you can maybe implement the same in Denmark. You can check out the eped.se to check out the doses as well. All right, first off, I think when I worked in Denmark in pediatrics maybe 6 or 7 years ago now, I think one of the most dangerous things in the system was when I had to calculate drugs that I couldn't really. I don't like if you don't work with children all the time, then you kind of don't know the doses, and you don't know whether it's a factor 10 or a factor 100 that is the right answer. So there needs to be I don't know if it's is 1 milligram right, or is it 10 milligrams, because there's such a big range in children. And in adults, it's just the same, right? So this is one of the more difficult things coming from coming from adult world and going into the pediatric world. And I think the ePet is such a great tool for this, and it's online, and you can go check it out yourself, right? So, but it's dangerous in the systems in the computer systems that we're using. It's really dangerous if there's not a calculator in these, because we do miscalculate a lot of things, and we don't know that it's wrong because we don't have the calibration to children if we're working in adults, right? So the system that we are using in Astrid Lindgren is called Take Care. It's the one that is being used in most of Stockholm. And don't be bothered about the details about the system. I just wanted to show you this calculator and how it can be done in the systems. So I have a burn victim patient. I want to order intranasal fentanyl. I have checked somewhere that it might be 2 micrograms per kilo. And I have this dose help, which tells me if I have registered the patient's weight out here. Now you'll see in the next slide, and I've registered it out here, and I was okay, 2 micrograms per kilo. That means that for this specific drug, which is 15 micrograms per milliliter, then I'll have to use this amount of substance, which translates to this amount in milliliters of the drug. Okay, and then it shows yellow here because it says here the dose range has been like this is overdosing for this 9-year-old of 35 kilos. This is overdosing, and I can check FAS, which is the same as pro medicine, but as I said, we don't do that. We use the instruction, which is the ePet, and if I click the instruction, then I'll get this, and then it says, and I know this is in Swedish, but here it says, from children 1 month to 18 years, the dose range is 0.5 to 1.5 micrograms per kilo, and it can be repeated every 50 to 60 minutes. And it also says like a warning here that this is really, really potent drug, right? And lots of other things. This is just one part, and you can access this yourself through the ePet if you write fentanyl nasal like this. This is in ambulances as well. Like this is a drug that is being used a lot in children in Sweden. So okay, so now I know the dose range instead. I'll go back and I'll write maybe 1. And that translates to 0. And then now it's not yellow anymore. Then it's good. And when I check overføre, or use this dose, then in the grader system, it's taking that. This is the marker that I click the dosing help, and then it's taking those 0.7 milliliters, and it's just using that. And this is such a great help. The calibration problem, you get this small warning, oh, it's overdose or underdose, and then you get this, you get the direct access to the actual ePet or dose to calculate it, what's the right dose, and then you get this help where you can just write the dosage. You don't have to calculate yourself, and that's such a big help. It's so much safer. So this I think should be in all systems. This is so great. I really love this. Okay, so now let's just go through the doses of the most common medications here, okay? The references for these doses are the ePet and the procedure book, the Swedish one, not the Danish one. I will show you the differences between the Danish and the Swedish ones and where they are. So paracetamol, what we do in Sweden is if they haven't gotten any previous paracetamol that lasts I think it's 24 hours, then you will give them a bolus dose of 40 milligrams per kilo. Maximally 2 grams. That's a lot, right? Usually we're afraid of giving children too much, but and adults too much. But this is sometimes you can give them like this. Like we do this all the time with painful procedures or pains when they enter the triage in the pediatric emergency department in Astrid Lindgren, and they have pain. They will get this bolus dose. That's all children will get this. And then after that, they can get a pain dose, which is 25 milligrams per kilo times 4 times a day, only for 3 days maximally. And it does say sometimes it has to be in the hospital that they are getting this, but I don't see the reason why. And we usually, when I talk to a lot of the pediatric emergency physicians, they used it for outpatients as well, and we did have some papers that we could send home with the patients where we used it as well, like patient information where it said so as well. So that was new information to me, that was a good dose that was a non-dangerous dose, right? Then down to the fever dose, which you go down to by day 4. If you used this for day 3 for 3 days, then you go down to this dose on day 4, which is 15 milligrams per kilo. I think the Danish one, there will be a pop-up here. I think the Danish one says 10 to 15. And here's the Swedish one from the Swedish pain, not the procedure book, but this pain book from Astrid Lindgren. And it says here, laddningsdose, like loading dose, and like continuous dose, underholdningsdose. So if you have someone over 2 months, then you'll give 40 milligrams, right? So that's what they give here. That's why, and then underholdningsdose for 3 days maximally here. Just so you know that I'm not pulling this out of anywhere. This is what the guideline says. And I've heard Jerome Hoffman's Jerome Hoffman, this emergency physician professor, has talked about this in his lectures as well, that we're probably underdosing on paracetamol, a lot of children, if we follow the Danish guidelines, which are neonates and children, 10 up to 10 milligrams. They're giving 10 milligrams times 4, right, or 40 milligrams per kilo per day, if I'm reading this right, or 50 to 60 milligrams per kilo per day on 4 doses, right? So that's on the max dose, it will be 15. So the Danish guidelines will use this, whereas we're using a higher dose range up here. And in my experience, I mean, it's hard to say whether there's a big difference, but I do think paracetamol is used a lot, and it's often enough. And maybe this is enough, but oftentimes for the big pains, like appendicitis pain, these work really well, and we often avoid morphine with these. Okay. Just a special case as well. Oftentimes we'll get IV as well, perfalgan, or IV paracetamol. And there the dose is a little bit less. It's 20 milligrams per kilo times 4, and then after 3 days it's 15. Ibuprofen. One of the pediatric emergency physicians taught me that they don't dose it less than 10. I think there's a dose range somewhere around 7 to 10, but they don't dose it less than 10. So 10, and then it's 4 times a day. If you don't, 3 or 4 times a day, depending on whether you go over the 1200 milligrams per kilo max. So if you have a 40 kilo child, then you get the max dose, because then it's 400 milligrams times 3, which is 1,200, right? And then there's always the argument that you do have 600 milligrams tablets, and they are given sometimes, but that's usually, like, if you ask pain experts, like emergency medicine pain experts, like Motov, who has the homepage Pain-Free ED, he will say that you have the ceiling effect after 400 milligrams 400 milligrams times 3. Then there's no additional pain gains. It's only anti-inflammatory gains. So it's mainly for rheumatological conditions that the 600 milligrams work. But you will get more defects and more side effects. Then you have Dextor, and the dose range is usually 2 to 3. We usually dose maybe 2.8 micrograms per kilo internationally, or IV in a little bit lower dose, especially if it's combined with ketamine. You should never combine it with cazirasan or clonidine, because then they will become very bradycardic. And usually you get lower doses for PVKs, right? And if you just have to lie still a bit, higher doses for suturing and MRIs and so on. Depends. Then fentanyl, we just went through it. That's the dose there. Clonidine, usually we'll get 1 to 3, and it could be given 3 times a day. And it's usually something you give in addition, like it's paracetamol, ibuprofen, and clonidine. And if they're being operated on, then no ibuprofen, but in paracetamol and clonidine, and then maybe some kind of morphine as needed. Then you have S-ketamine or also ketamine, depending on what kind of ketamine resolution you have. Intranasally, solo, or in combination with other things like Dextor. The problem is you can maximally give it intranasally 15 kilos because otherwise the volumes will become too big. Sorry, there's a milligram per kilo. I forgot to write per kilo here. And the volumes being too big intranasally is because it's beyond 1 milliliter. You can give it perorally, but it tastes bad, so you have to give it in juice. So the problem is sometimes if the child is like 17 kilos and you really have something really painful, how do you salute that? And we can talk about that later on, but oftentimes, depending on the painfulness of the procedure and so on, ketamine might be used, but then you might sometimes use it intravenously, but with a bigger setup because that's more dangerous and more complication prone. And so on. There are different ways of handling this, and maybe it has to be done in OR, and so on. Then xylocaine, you add 2 milliliters of sodium bicarbonate to 10 milliliters of xylocaine, and then you get this buffered xylocaine. And the dose here is 4 milligrams per kilo. The more, like, I have in some of my lectures talked about LAST syndrome, like local anesthetic syndrome toxicity. LAST syndrome, I can't remember that, but LAST syndrome, like toxicity from analgesia, local analgesia, and there are different solutions have different risks, and usually it's if you have a really well perfused area, then there's a higher risk as opposed to something with a less perfused area, and so on. Right? So, but in general, 4 milligrams per kilo is the EPET recommendation. And then we have lat gel for wounds around 3 to 5 centimeters. You combine low lidocaine 4% with adrenaline and tetracaine, and it has an effect after 20 minutes. And you give 0.1 milliliters per kilo, usually 3 milliliters, but it has to be under a band-aid. So usually 3 milliliters is like you don't go up to the max usually. For intranasal administration, you will need to do the following. You have to like it says here, like max volume 1 milliliter. It has almost the same time to effect as an IV. You should not be using it with nasal fractures or severe bleedings, or if they are severely have a cold, like their nose is stuffed. That's only relative, but it's because you can try, but you don't know whether it works or not. So you will suck their noses dry if you can with a sucker. Also, then you'll get the medication. Remember that there's a dead space here, so there's a little dead space being collected here. So you will have to subtract like the first dose that you're giving. There should always be 0.1 milliliters extra in the syringe. So if you're giving 1 milliliter, there should be 1.1 milliliter. Or if you're giving like 0.7 milliliters, it should be 0.8 milliliters, so that the first little milliliter is being collected there. Then you put on what they call the olive on the syringe, and then you put it into the nostril, and then you inject really fast. And usually it's this is 1 milliliter syringe, but you only push in 0.15 milliliters at a time. So do it sequentially. And you should try to, like they say, push it to, you should aim it towards the lateral part of the nose, a nostril, not the septum, because the septum hurts. And the idea is that you should push hard, because then you'll create a lot of small particles, as opposed to just getting the nose wet. So you need to, like, you have to atomize it, right? These are called also atomizers, I think. And you can buy atomizers for like local anesthetics and in the oropharynx as well. All right, and it's important to half the dose should be administered in one nostril and the other in the other. They say, yeah, and so on. And it's 30 seconds in between each. And so oftentimes 30 seconds between each administration. And oftentimes children are moving about, and it's really difficult to give them these. Like part of the reason why we're giving them intranasally is because they're hard to put in IV lines on, right? So, or it might, so it's, this is sometimes difficult, sometimes also really difficult, but oftentimes in my experience, it works wonders. Is really a good technique to know and to have in your hospital. All right. Here I've just posted, and you can pause the video if you want to read in Swedish. Here, this is just from the procedure guideline. I'll just go through really quickly about these medications. Clonidine or cadapracin. This is this hypotensive, or blood pressure medication that also has sedative and pain medication properties. You will most importantly is that if you have bradycardia, it's a problem. So it should not be combined with Dextor. And sometimes there are some children with ADHD that might need higher doses. You need to, if you're giving them this, I mean, we did give patient if you have a fracture and if you have a fracture, then you will usually give paracetamol. You'll get paracetamol, and then you'll get clonidine with you home, so you can come in a couple of days and be operated on, right? If you're not being admitted, if the pain can be managed with a cast and paracetamol, then you usually get some syringes of like peroral, oral clonidine home as well. Maybe 3 or 4. So the like really tight surveillance is not necessarily needed all the time here, but with higher doses and especially with IV, yes. And especially with combination with other drugs that may induce bradycardia, you should probably not use that in the first place, but if you do, you should. Usually with both this and Dextor, you can pain, like you can just rub their chest or pain stimulate them, and then they will wake up. So here's Dextor. It has no analgesic properties, okay? But it can potentiate the effect, like the pain properties of other drugs, though, it says here. And it can be combined with ketamine, especially, and paracetamol and so on. And this is important that it works within 20 or 30 minutes. It has a duration of 30 to 60 minutes. And it can be used in, like, it's much of the same. I don't want to go through all of this, but usually we use it intranasally. You have S-ketamine, and we've gone through this before as well. Here again, 15 kilos, especially, so it's quite small children. If it's bigger children, then you'll use it in soda or in some kind of, like, you'll have to drink it, and you have to give some kind of taste improver like soda or something like that, because it has a bitter taste, and you'll use this dose range. And the main risks here are that they can become like dissociated and get hallucinations. And I did have a child that got hallucinations, and it was more like there's an amnesic effect, right? So they don't remember it, but the parents were like very afraid of this, and they were kind of not traumatized, but they thought it was a bad experience, that the child, we haven't explained to them that their child could get so dissociated, like so hallucinative. And it worked out okay, and we did the procedure, but It's just something that you have to tell the patients and the parents that they can get a bit agitated as well. And especially if you want the patient to lie still, it's really important that you give it in a calm room, in a calm environment, and slowly, right? So that this agitation or hallucinations are less so. But they may develop it anyway, and then you can combine it with midazolam. But then you have to really lots of these things. When you've done the procedure, which is usually short, the procedure part is really short, but the lead up is really long, and oftentimes the parents just want to go home afterwards. And these patients with Dextor, especially, ketamine especially, but also Dextor, they have to be on monitor at least for an hour afterwards, depending on how they're doing. But we want them to be up and walking and talking, or at least some time has passed, maybe an hour. Some guidelines would say more so. Follow local guidelines on that. And we have esketamine as well. And we have diazepam, as we talked about. We probably know about diazepam. Is really good for most things where there's anxiety involved, right? And lat gel, here again, 20 to 30 minutes. We'll talk about it right away. And so on. Morphine, L-fentanyl is not something that we use so much, but it's something that is really used a lot in pre-hospital sector and in certain emergency departments, and also by anesthesiologists when they come down and help us with the sedation, sometimes with really painful procedures. And we talk about paracetamol orally and intravenously. It has an effect around 30 minutes, a maximal effect after 1 to 2 hours, which is why we recommend them to take it 1 to 2 hours before, and so on. Ibuprofen, and we have this 7 to 10 milligrams, right? And so on. And loose gauze, which is nitrous oxide. All right, when it comes to these things, the timing is really important, right? So I want to do a procedure on this child. Then the timing becomes extremely important because the time to effect and the time to peak effect is really different. So xylocaine, like buffered xylocaine local anesthetics, 10 minutes. Latch gel, 20 minutes. Dextor, 20 to 30 minutes. EMLA, 1 hour. Paracetamol, 1 to 2 hours to peak effect. So if I have a procedure that they need to do, then I have to plan it. We have to do things several hours in advance, right? So for the procedure, I will give the NSAID. Let's take an example. So if I have a patient who has a fracture and I want them to go home with the cast and I want to reduce this fracture in the morning, then I tell the patient, you have to go home tonight and you'll get your paracetamol, you'll get your NSAIDs because you're not going to be operated on right now. So NSAIDs are okay. And you can get your clonidine as well if it's really painful. And then tomorrow when you come in, I will give you with you to go home. I will give you EMLA band-aids to apply 1 hour before you come in, and paracetamol you have to take that 2 hours before you go in, and you have to take it in the dose. If you haven't taken it today, you'll get 40 milligrams per kilo, or if you have taken it today, you will get 25 milligrams per kilo. Okay, and you can also use 10 milligrams per kilo of ibuprofen. Then, I put EMLA twice. Yeah, and then once you come in, now you're in the department. You've done all the things that you have to do at home. Then you come in, and I can't let it go too far, right? Because then the time for this will run out, and this time for this will run out. So I have to when they come in, we have planned you come in at 9, and then I'll give you the Dextor and the lat gel maybe, and then I can use then you can get xylocaine, and then we can in local, or we can replace Dextor with nitrous oxide, maybe alfentanil here as well, and then you can do the procedure with local xylocaine, and then we can reduce the fracture after that. But it has to be planned, right? And this is hard if you have maybe you usually have 4 patients going at a time, so you have to just like plan all your procedures, right? So and collect your team. So you have to have a routine about these things. Okay, so then we have a dilemma. And one of the dilemmas that I often found that I had was I always want to give the child as little drug as is needed, right? But on the other hand, I want to make sure that I don't have to go about it twice. So I have a dilemma here with if I want to suture, let's say this is a suture of a child, and this is a plan that is like if I want to suture this child, I might have to I'll give them this, and then I'll give them I might not give them EMLA, but I'll give them paracetamols, I'll give them Latgel, and maybe Dextor, and then I have 20 minutes after that, then I have to give them xylocaine, or maybe I'll just do the procedure here. But I can do the all-in approach where I do Latgel, Dextor, paracetamol, and xylocaine, right? Or the minimalist approach where I give them consecutively. I'll give them this, but I don't give them Dextor. I just give them Latgel. I give them Latgel, and that will work after 20 minutes. I'll try to suture, but it fails. It's hurting, and they don't want to, and I lost the alliance now. Okay. Then plan B. I'll just do Dextor, but now, the Latgel is wearing out. Then I might consider doing local xylocaine instead. I wanted to avoid that, but then I have to get. So you see, either you do an all-in approach, or you are a minimalist and you try to do it consecutively. Like we'll just do it with this, but then the problem is then that the effects of this might wear out, and this. If it's in the middle of the night or it's like the child is not that old and so on, then I might do a more all-in approach. But if it's a child that is quite cool and we can do it without problem and so on, then I'll probably try the minimalist approach, and I'll explain them because here they can go home right away after I've done it. Here they have to wait, right? So the take home is like, in general, like have a plan that fails well, and think about if this fails, how do I do it then? And that's what they also are talking about in the procedure books, like have a plan A, a plan B, and a plan C. Okay, so common combinations of drugs. Of course, always use non-pharmacological, always use EMLA, always use paracetamol, maybe NSAIDs before as a base. And here are some examples of combinations. We already talked about for operation. Usually, if you have an appendicitis, you're going into operation and being admitted, and then you want to be fasting, so I'll give you IV Perfilgan. I've never gotten a good answer of whether or not you can get drugs perorally. Some anesthesiologists says it's okay, others don't. To be safe, you can give it IV until further notice, and then clonidine 3 times per day, plus minus morphine. That's pretty standard. If you have a child you have a painful procedure in a small child, it should be less than 15 kilos. I made an error there. The Dextor plus ketamine is good there, but you can do it with less as well. Depends on the situation and the painfulness of the procedure. Most commonly, you'll do Latgel and Dextor, maybe Dextor, not necessarily. They don't, like if they're big enough, usually you can, and they're not scared, then you can usually suture without Dextor, just with Latgel, or just like an adult with local xylocaine sometimes as well. If you're going to do an operation on them and send them home in a couple of days with a fracture, then you'll have a cast. The cast is usually very much pain reducing, and then you use local you'll give them paracetamol, usually 25 milligrams per kilo for the first 3 days, and NSAIDs maximally for 14 days, and so on. And then you'll give them clonidine up until the operation, which is maximally 5 days away, but usually less so. Be careful combining clonidine like Dextor and also intravenous drugs. Any intravenous ketamine is something that should be done in a safe procedural environment with a bigger setup, because all of these sedations are being used, like Dextor and all the others, intranasally. They are being done in ambulances or in normal patient rooms without a big setup. Maybe a telemetry, like maybe a saturation monitor, nothing more than that. But if you do use IV ketamine, then you need to do more, right? And if you're using Dextor, then you have to have a telemetry and so on. So monitoring is important as well here, right? But don't, and this is not like I said, careful. This is like, don't combine these two, clonidine and Dextor. This can be combined, but be careful. And they need to be more, monitored. Okay, so a bit of common situations and treatments. So for burns, usually you'll get intranasal fentanyl, and you'll get local silicone pads, and then that's like 95% of all burns will just get this, and it'll be all right after they've gotten water on it for 20 minutes or so, and keep them warm. And then operation, if it's big burns, right, then they will have to like. But this is the standard treatment for most of burns, and also when you have to like put on the band-aid and so on, put on the dressing and take off the dressing as well, right? But if they need, like I said, operation here, but like if they have to be sutured, sorry, not sutured, but if they have to clip the blisters, if you have to take away the blisters, then usually you will do it in these, and that's enough. Reduction of fractures. There's a high variability depending on age and anxiety and how painful the procedure is and what kind of fracture it is and so on. But some examples are, let's say, a 30-degree dorsally angled antebrachium fracture, like ulnar and radius. In a 9-year-old, well, you could do method 1, which is virtual reality for the sedation kind of, or hypnosis, and then axial regional block after they've done the VR for maybe 10 minutes. And then you'll wait additionally 10 minutes after the regional block, and you'll do the reduction. And we've done this many times. It's a really, really effective way of doing it. Method 2. Method 2 is if you don't have like regional blocks and you don't have maybe VR, you'll do EMLA, and then you'll set in the PVK, a peripheral venous catheter, and then there's an hour between the EMLA and the PVK, of course, and then once you have the PVK, then you'll get nitrous oxide, like loose gauze, and then maybe small doses of L-fentanyl to remove the cast. Once the cast is removed, then you'll mark the fracture line with an ultrasound, so you know where to put in some local silocaine. Once you have done that, then you'll give a small additional dose of L-fentanyl, and then you'll give the local silocaine in the fracture hematoma, what we call a hematoma block, and then wait 10 minutes for that. And meanwhile, they're not getting any loss, like nitrous oxide gas. And while you're giving the nitrous oxide gas, you have to like have a dedicated person who actually talks to the child and guides them through, like maybe like very visually guides them through a split splash or a roller coaster, or they have to find Wally on a page or something like that. That's usually the techniques that we used. But this is something that requires a huge, like a big team, at least 2 or 3 people, like one person doing the cast, one doing the silocaine reduction, silocaine injection and the reduction. That's usually me. And then maybe 1 or 2 people giving the like usually 2 people doing the loose gauze or nitric oxide and doing the L-fentanyl, right? So it's a 4-person team, at least. This one is just someone doing the cast, someone doing the block, which could be me, and one doing the VR. So that would be a 3-person team. So depends. And if they then have, let's say this person also has autism, like this child also has autism, then this might be out of reach, right? Depending on if it's a high functioning autism or not, and when you might have to go to the OR instead. For finger block, oh, that's just and I just wanted to show the spectrum of the variability here. And we haven't even taken into account the ages and the amount of anxiety and so on. So it's good to have a plan A, plan B, plan C, like in the procedure books. So finger block, that would be an EMLA, and then a finger block, and then do the sutures. And suture, like if glue doesn't work, but usually it does work. So there's a lot of things that could be glued, which we're suturing. So if we do a suture, then with lat gel, if we do have lat gel, and then let's take an example of a 4 to 6 year old who's not scared, then lat gel without any Dextor, and then suture. But we could do lat gel plus minus ketamine or Dextor if they are scared, and if they're not lying still. That could be plan 2. And it depends on what kind of time of day and so on. And depends on whether they're anxious or not, and so on, which we talked about. If it's without lat gel, if we don't have lat gel, then a good method would be EMLA, and then do a local xylocaine through the EMLA. So EMLA 1 hour, and then do a local xylocaine through the EMLA, and then you could use Dextor. You could also use midazolam is really good here, especially if they're a bit older. So you can use VR for 10 minutes, and oral diazepam or midazolam in this dose, which maximally it might be it seems like a big dose for a child, but this is a good dose for this. And then wait for 20 minutes, and then you can do the EMLA, a local xylocaine, and wait for 10 minutes, and then you can suture. And this method I didn't personally actually use during my time, but we at one point our lat gel it disappeared. There wasn't any more of it, and it wasn't getting back. So towards the end of my rotation, and then we would have to use this. And I didn't get into a situation where I had to use it, but this I'm told is a really good method as well. I just wanted to go through that method as well. So if you have a wound, then you'll put on EMLA here and on the wound edge here, and then you'll use this this common method, going through the wound edges here, and then going all the way in with the syringe, and then I'll usually sedate on the way back. There are different ways of doing it. You might also go a little bit in, then sedate, then a little bit in, then sedate. But I find that you're pricking the patient more times then. So I'll usually go in all the way, and I'll sedate, or while I'm moving back, I'll release xylocaine into the wound. And you'll do the same on the other side. So that's that technique. Another technique you could do in different areas, like the hat technique or the hair apposition technique, where you have a wound in the scalp, and then you'll twist a bit of hair on that side, a bit of hair on that side, and then you'll cross them, and then you'll cross them again, and then once you cross them, then you'll pull tight in both directions, and you'll put a bit of glue on right there, and then that works magic. It's really good. When it comes to gluing near the eyes, you should always be careful. You could use either just a cloth here, or you can use Tegaderm like so here, because that's really tight, right? So that's the main thing with glue. That's the main contraindication with glue, right? That there might be a problem with this. Okay, talking about sutures. There are in general 2 or 3 kind of sutures that we use. Mainly we use Ethelon, which is a non-resorbable one. You could sometimes use Vicryl, which is a resorbable one. And you have the fast one, which will resorb within 40 days. And the other one was just 60 days. The manufacturer sometimes says 7 days for this. Just tell the patient that there might be a slight bigger risk of infection because of these sutures are there so long, as opposed to this, which is taken out by the vårdcentral, by the primary care physician. Sorry, the primary practice physician. We do use Vicryl for something like nail bed repairs, where you do put the nail on again afterwards, if you do that. For deeper wounds where you suture deep, or if you have if you have a procedure where it will hurt the child a lot taking the stitches out, or it will be anxiety provoking, like patient with autism, or someone with a facial laceration or finger laceration. Those times Vicryl might be a better option than Ethilon as well. But most of the times Ethilon is the one that we use. And these, like what kind of, like, the smaller the number, the bigger the threat. Like, so 10-0 is really fine, and 1-0 is not fine. And and depending on whether it's a scalp, then it's usually the 7 to 10 days and so on. So the time when you remove are different, right? And then for gluing, limning, it has to be new wounds. It has to be lead approximated, like easily approximated, without a lot of tension. So if you have a wound over an area of a lot of tension, you should not use glue. It should be kind of straight wound edges, not too complex wounds. It can be used with suturing, so that you suture part of the wound and you glue another part of the wounds, especially if it's really hard to sedate the patient for the suture and so on. And it's important to always tell the patient's parents that there will always be a scar, right? Scarring, we're trying to reduce the risk of or improve the cosmetic results. And if you listen to Justin Morgenstern's evidence walkthrough on this, they don't have to be that approximated, the edges, to get the same result cosmetically, right? So it just has to be almost kind of approximated. And we of course we approximate it as much as we can, as long as there's no tension or ischemia on the wounds, right? But probably we overestimate the tradition and the evidence on this, the traditional effect of this. So there's not a lot of evidence in this area, and the evidence, as I understand, the small amount of evidence that there is, says that the wounds edges don't really have to be that perfect. They just have to be similar in most areas of the body. There are some areas like the lips, where the red of the lip has to be perfectly aligned, right? So there are circumstances where you have to do really precise sutures, but most of the time the wound edges just have to be kind of approximated. You can use stapling for some things, but I actually never used stapling. I used glue or steri-strips, and steri-strips can usually be used in along with gluing, right? That's usually steri-strips and gluing or suturing, but all of the three can be combined with each other. And here's the link for this information. Okay, now moving along to cases. And I brought along a lot of cases just to show you the spectrum of these injuries and how to approach these things. Okay, so let's get going. Okay, so let's start with a few finger cases. So our first case is around, and again, I've tried to make all of this anonymous, so the ages are different, and the pictures are taken from various sources and so on. So, so let's say a child who's about 6 years old is kicked on the finger, and this is what the finger looks like. So there's a obvious misalignment, and we'll be focusing on how to actually manage this. So first of all, we will or how to manage it sedation-wise and pain-wise, and this child doesn't need to be in a lot of pain. Usually, if they're just keeping their hand still, it doesn't hurt too much. I've had some children who come in with similar fractures, and they don't really find out until later that they have a small fracture. So sometimes these are not as obvious as these, but we do an X-ray always, and we see here that there's a definite misalignment here. with a small fracture down here on the proximal phalanx, the proximal part of the proximal phalanx. And when we then look at our guidelines, we'll see that if a proximal phalanx has a either metaphyseal, meaning here at the growth plate part, or diaphyseal here at the shaft. If they have a fracture in either of those places, and a 10 degrees misalignment is or angulation is accepted, and a 2 millimeters shortening, and no rotation, rotation of the fingers are allowed. So in this case, if we will measure this to maybe 14 degrees. So we'll have to do something for this kid. We can't just give him a cast or give him this twin. We can't just tape his fingers together. We need to do something more. So what we would do in this, so I would order a EMLA. This is a EMLA over the site where I want to do local, because this you can do in local, because this is quite a big kit. If the kit was smaller and you wanted to do a finger block, then probably we would need to use Dextor as well, or ketamine, to be able to actually just get the xylocaine in there. But for bigger kids, maybe above 5 or 6 years old, something like that, and depending on how cool they are and so with the entire situation, then usually I've been able to do it. But with kids around 1 to 3 years old, it's harder, right? So what we'll do, we'll put on EMLA. We'll just wait an hour, and then we'll do a finger block, meaning maybe 1/2 to 1 milliliters of xylocaine here. I usually do it in the old-fashioned way up here, but there are different ways of doing it. You can do it from the volar side as well, and so on. But I've never learned that, so I'll do it in the normal way. Here, and give some xylocaine, and then further down here, give some xylocaine, and here, and maybe on the X-ray you can see the folds here. I'll maybe around this area I will be doing the lidocaine infusion or injection. And then you wait 10 minutes, and after that you can do the reduction. And this is not a reduction video, but I'll tell you how I'll do as well. You usually with these you can just push them, or you can have a pen here in the middle, and then push in this direction. And then after you've reduced it to clinical, you can also just like pull on it. And once you've done that, then you will have to check whether there's a rotation problem afterwards. And if there isn't, and they can if they can fold their if they can flex all their fingers and they're aligned normally, and the other hand is the control, then everything is all right. Then you can send them for a control X-ray, and then they will follow up. And most of these fractures, at least in Karolinska, they would be followed up after a week. And if you've done anything to the hand, like you've done some kind of manipulation, or anywhere if there's a fracture where you've manipulated or reduced it, then you will be followed up by a specialist in children orthopedics, and if not, then usually it's we send them to a normal outpatient clinic for orthopedics, where they also see children, but not necessarily a specialist. And usually they will have almost all of these. As I tell all patients with fractures that, okay, so there are 3 options here. There unless the fracture is really, really bad, and there's some red flags which we'll get into later. If there are any of these red flags, then you have to be operated on and do something quite seriously right now. That's really uncommon. So usually the majority of the patients that you'll meet will have a fracture, and you'll have to do one of three things. Either you do, if the fracture is aligned and well, you do conservative management. If it's really misaligned and they're in a lot of pain, and it's impossible to reduce, or it's not going to reduce well, like a comminuted fracture or something like that, in some areas of the body, then you will go to operation after consultation with your children or pediatric orthopedic. And then the in-between pathway, like the third option, is, well, the fracture has to be reduced, and you can do it without the operation. And it's really important to tell the patient's parents that this is a attempt at not operating, right? It's an attempt to avoid the operation, um, and most children will grow in a like they will heal in a really fantastic way if especially if it's metaphyseal. We usually call it the magical metaphysis, and the very not magical diaphysis. So if it's a diaphyseal fracture, then usually they won't heal as well, and they have to be reduced. But more angulation is accepted in the metaphyseal region, as long as it's not a complicated Salter-Harris fracture. We'll get into those. But so those are the three pathways: like conservative management, reduction, and operation. And the reduction can either go, like if you go the reduction pathway, either it goes to operation if it's not successful, or if the fracture slips despite being reduced, or it goes to conservative management. And it's important also, if it goes to conservative management, it's really important to tell the parents, well, this is still something where, if we go to conservative management here, you might need to get another, like you'll do an x-ray in a week to see if it's still acceptable. If it's not, then you might go to operation, right? So you're still not quite out of the woods, even though you are sent home with conservative management. So information for all of these patients and parents are really important, right? But we'll get into that in the later cases. But here, EMLA, local silicane, then you can tranquilize the finger in these kits, and then you can do whatever you want. Okay. And here we have a post-reduction x-ray where the angulation is acceptable within 10 centimeters. Usually if they come in late, the later they come in, the harder it is to actually do anything with the finger, because it's so swollen. Okay, so better to do these early than late, because if they come the day after, usually they're quite swollen and the reduction cannot be perfect. Okay, another patient here, a 8-year-old with a twisted thumb during gymnastics, and another here we see also a basal phalanx of the thumb with a angulation here, and same thing here. When it comes to the thumb, as opposed to the other fingers, it's my clinical experience, and I have seen a few lectures from hand surgeons as well, where they tell us that we need to put in more lidocaine for these finger blocks than for other finger blocks, and that's my experience as well. And the same goes probably for the bigger toe. So usually I will do my finger block down here or here, here and here, and then you will get a good effect on the finger. But to be able to do this, you will do EMLA again in this hand, and you will, in this case, we used to be able to do the finger block. You could do that, have done that in the other case as well, either by Dextor or by nitrous oxide, or in this case, this was a bit bigger child, above 6-7 years of age. Then you can do virtual reality as well, so to be able to like get the fear element of this down. My DAS lamp could have worked as well. So there are different ways of getting to it, but we'll try to do the most minimally invasive procedure. All right, so virtual reality we chose for this particular child, but nitrous oxide could have been chosen as well. and then we reduce it in kind of the same way. Pull and then push it toward that that way. And then always we check with ultrasound before and after, and also X-ray after. Check the distal, like the neurovascular status afterwards, always as well, before and after casts. Okay, next case. So we have a 8-year-old ninja. A ninja because he was doing some kind of karate, and he stumped his toe during training, so that the bigger toe kind of did a flexion, like a 90-degree flexion, with him standing, like putting his weight on it. The X-ray was normal, but the big toe looked like this. Here again, you have so the X-ray, there was no fracture, and as I've seen, as I've talked about in other lectures, and Arun Sayal from EM cases, and from I can't remember the hospital, maybe Stony Brooks, maybe, but I can't remember the hospital. But in Canada, he will always say that this is really important to take into account the pre-test probability. All right, it's right up our alley if you've seen the other videos I make. So if you have a high pre-test probability, then you should use the scared of mnemonic to, if the X-ray is normal, then you should think of other things that could be like something that you need to do. So the scared of mnemonic is septic joint. This is not the case here, right? Compartment usually is pain out of proportion. Some areas of the body are more prone to compartments, such as the proximal tibia in children. The A is abuse. Are there any risk of abuse? And that's highly probable in a lot of children, or you have to have a low threshold for expecting that or thinking that, but no such suspicion here. But some injuries are particularly it's an entire lecture on its own, and I've already talked about it in another lecture. But in general, the entire situation, if they're seeking out care late and so on, if it's a fracture that is in a strange place, if the parental child's communication is weird, and so on and so forth, different signs, right? So that's abuse. The RE is read either read wrong, so that the X-ray is read wrong by the X-ray doctor, like the radiologist, and if read wrong as in, it's obvious, it should have been caught. That's why you always have to read your own X-rays as well. It's not because the X-ray or the radiologists are bad. It's just most of the time is because we have the patient in front of us. It's easier for us oftentimes to actually see where it hurts the most, and if we don't write to the X-ray doctor or the radiologist where it hurts the most, then they have no chance or little chance of finding these nuance fractures, right? So that's read wrong, and RE is also referred pain. So if there's pain that's usually knee pain, whereas the hip, that's actually the problem, right? So if you have pain in a joint, if there's subjective pain in a joint where there's no pain when you touch it, then you should always think of referred pain, and the classic one is knee pain in orthopedics, right, where it's actually the hip. We do see that in children, but usually not traumatic ones. D is dislocation. So dislocation, some dislocation, like you should never leave the emergency department without it with dislocation. There are a few exceptions, but most of them, like if you have a dislocation of your shoulder joint or whatever, then you should never leave the emergency department without getting it into joint. There are certain dislocations that are really terrible and are dangerous, right? So knee dislocation in Sweden, they usually come in as a knälux, knee dislocation, and there's a terrible terminology because what they often mean is a patellolux. but they call, like the ambulance usually call it the knee locks, and the knee locks is totally different. That's an emergency, but the patella locks is a common, not difficult to manage thing that will heal with time. So that's the scared part. So the off, that is occult fractures. Sorry, that's not occult. It's operative. So it's operative soft tissue injuries. And operative soft tissue injuries, that could be, for instance, in the leg, it would be in the leg would be the quadriceps, a quadriceps rupture, for instance. And then the F is the fracture, or occult, or fracture not. So it's like, and as opposed to the one where it's read wrong, then an occult fracture is where the X-ray is just not sensitive enough to actually pick it up. I will say that there are other red flags that I would always think about, even though everything looks right. I will always think about open fractures, even though, yeah, that's one of, like, is there genomstic? Are there like is there a hole where a fracture is? Before I send someone home with the conservative management, is there a neurovascular compromise? And especially there are certain fractures that are high risk, like the supracondylar fractures. I've had a few children who has had compromise when we have those fractures. So yeah, so that's my addition to that scared of. Always look for open fractures and neurovascular compromise. Okay, but that's like how we think about these. If the X-rays is before we send them home, what's the most dangerous thing? Then of course we have to think about pain management and casts and so on. But for this particular case, again, what do? We know it by now. For this case, we would he's big enough so we could do EMLA. He was quite cool, so we didn't do virtual reality or anything like that. We did it was all right to just do the blockade. And usually, if the bigger the child now, like we should ease pain, but also doing a huge setup is sometimes bothersome for both the patient and is resource demanding. And usually if they're big enough, then usually it's not a problem to, if you have EMLA and then you do the toe tranquilization and so on. So it's always a evaluation, right? But in my experience, it works well even without the virtual reality with most bigger children. Okay. And then suture, and the suture I cannot remember for toes, but it may be 5-0. And this wound went all the way down here on the side. Okay. Then next case, a 9-year-old who crushed the finger on a beam. So fingers are hard, I think, and there's high variability on how to manage these, and also high variability on what kind of injuries you get. But in general terms, what are we seeing here? We are seeing, let's zoom in, we're seeing a blue nail, meaning a subuncal hematoma, a total subuncal hematoma. We might, this is like where the nail, let's put up this picture. So we have the nail fold here. This is a nail fold. So it seems like the fracture, or not the fracture, but the where it was injured, where there's a wound. I believe it's here, and it was here and up here. So what we always want with nails is that we want to check whether there's a fracture. There are certain fractures, Seymour fractures, that are they have to be managed quite like a bit more aggressively than like a tuft fracture. You have these tuft fractures where it's just a point, the tip of this area, the tuft, the bony tip, and that is crushed, and it was crushed here as well. But usually they heal well. There are again some controversy about all of these things. I'll be saying here there are controversy, do we have to remove the nail here? I believe no, because it's sitting in the fold and it seems to be intact. So there's no reason why we should for nail bed lacerations and tough fractures, the EM cases would say a nail bed laceration should be suspected in the presence of some ungual hematoma or commonly displaced or of the distal phalanx. Remove the nail to repair nail bed only if there's a large subungual hematoma, more than 50%, that this is, or and the nail is partially avulsed, it isn't, and the distal phalanx is displaced. So we should not remove the nail according to these 3 criteria here. I've seen different, like there are different takes on this. Just I have not been able to, despite my efforts, been able to find a concise answer for fingers, because lots of it is religion and experience from hand surgeons and so on. Soft fractures that are displaced on the dorsal surface require reduction in the ED. That's also controversial, I would say, but if they're really displaced and it's going down, then yes, sometimes they put like a nail in through it to align it. And if we have to remove the nail, right? But if we do remove the nail, or the nail is already removed, then we have to repair the nail bed, like the nail bed down here. And it's important we do that with Vicryl and not with ethylone. So we do the Vicryl with resorbable sutures, and then you'll do a suture. You'll always try not to suture here, because this is where the nail grows from, so don't suture in this area. Always try to suture out on the side. And here I hear different things as well, but some of the hand surgeons believe that you shouldn't suture at all in the nail. You should suture here and here and here and here, and then with like a bridging, like they cut a small hole here as well, and then you have like a figure where you can, like an X fixture suture, where you don't hit the nail, but you kind of fixate the nail with sutures over here and here. What I've heard from hand surgeons in Sweden, in some lectures there, and also some courses I've gone to with these kind of fractures, here I would put I would put one here and here and here and here, and then follow up. And I would say to the patient that the nail might fall off, but usually it will be okay. I will show you some references so you can look this up yourself. For me, it's quite a difficult area. I think we have a thing we haven't talked about is that if there's an amputation as well, then you will have to there's a grade 1 where it's just the point, or a grade 1 where it's, I think, a grade 1 where it's just finger, and you see bone, but there's no bone involved. Grade 2 where it's the bone involved, and grade 3 where the joint is involved. And grade 1 you can 1 and 2 you can manage in the emergency department, and 3 are usually special cases. Yes, and then there are this controversy whether the nail has been removed, should it be put into the nail bed again. Many hand surgeons think it's essential, but the Ninja trial came out, which was a multi-center superiority randomized control trial with 450 children suspected nail bed injury, found no difference in the number of surgical site infection around 7 days or in cosmetic appearance between children who had fingernail replacement substitution after nail bed repair and those who underwent repair without fingernail replacement. So in general, after the Ninja trial, I think it's quite clear that it isn't that important probably to put in the nail. If the nail is avulsed, or like if these 3 criteria are met, it's probably not too important to put back the nail. At least the injuries would be less than 450. And I believe there was a little bit higher maybe risk of infection with the nail in. What they usually do if the nail is compromised or damaged beyond repair, then it has been advised for some, like either you put in a small tin foil from a suture kit and shape it like a nail and put it in and suture it in, like so, with sutures there and there, or you could do it with you know, when you have a Ringer's acid, Ringer's fluid, and then you have the small chamber below where the drops drop down. If you cut that out, the small chamber, then you can put that, like that is circular formed, and then you can put that in as well. You can check the references for these if you want. What we do with these, according to our guideline, this is a classic klemskada, like a you see these a lot in children. Usually, you'll not do. If it's a tough fracture, you won't do anything. If it's a proximal femur fracture, then you have to have an emergency operation within a subacute operation within 24 hours. And give antibiotic with an open fracture. This is an open fracture because there was a tough fracture and there was this. I'm not sure whether this lives up to the definition of it, but I usually give antibiotics for this. I haven't seen anything against that. And here is the technique that I used, how we were sewing this down. And even though this is a little bit different fracture, this is not a this is where this entire thing has gone up. Yeah. All right, another finger, and here is a smaller child with a finger in the door. Looks like this. Same thing here. How would we do? We would do EMLA. Just like in the previous case, EMLA, and then do a finger block. Because this is such a small child, we would have to sedate so that they don't move around when we do the EMLA. So we will probably do. This is a like a stepwise process, right? So we'll do paracetamol and maybe NSAIDs. We'll do finger block after EMLA, and to be able to do the finger block, probably we'll need to do some kind of ketamine or Dextor. Ketamine would be better in this case because it's also pain reducing, but they might move around a little bit more. And this is an area where we may need to hold the child a little bit, even though they are managed, because it would be overkill to get this child to an operation, like a general anesthesia. There's also risks there. So this is a gray area. I'm not quite sure how anyone else would manage this, but this is how I experienced this being managed. Where ketamine, and usually like just a little bit of gentle holding the child on, so that we can get the injection in, and then after that, usually they go back to being calm. And the same thing here. Again, here the nail is. The nail was here, but there's you have to sew this up and see if and usually as few sutures as possible here. Okay. Oh yeah, I think I forgot is that if it bleeds a lot, like it did in the last case here, then you would have to you can do a finger tourniquet with a glove to reduce that. Okay, so here's also a small child, a toddler with a finger injury in the door. Here the nail is unhurt, but the top has gone up, like a small and like almost an partial amputation of like grade 1. Here, same thing. EMLA, we'll do EMLA, and then we'll maybe do some kind of Dextor sedation or ketamine, and then we'll suture. 10 minutes after the finger block has started to work. And here's the end result after that. And then they will have to follow up as well. Whether they follow up by a hand surgeon or by someone else, like a primary care physician or nurse, is beyond what I actually know, and depends on local guidelines. But in general, the more complex injury, the more the more they should follow up by hand surgeons. Here, I think it will be okay with a vårdcentral, like with a primary care, because it seems quite uncomplicated, and you just need to remove the sutures, right? But I could be wrong. Follow the local guidelines for this. Then here is the little finger as well. Again, this is, if you looked at the guidelines before, is 10 degrees angulation is accepted. So this is far too much. It's almost maybe 30 degrees here. So what do? We, again, EMLA and put in xylocaine. Depending on the age, we might need Dextor or virtual reality or something to like reduce the anxiety about it. And then we reduce it with a pen here, and then pull, and then maybe push in that direction. And here's the after picture. It's not perfect. There was a lot of swelling in this case. So it's not perfect, and probably not quite 10 degrees, so it would have to go to operation, this one as well. So here are the trials for the finger, and like the lectures on YouTube by the British Society of Hand Surgeons, and also the Swedish one, Akuten Tips, here, where they have handkirurgi på akuten, hand surgery in the emergency department, and then EM Cases have done a great podcast on this as well, where I had some information from as well. All right, we'll move on to another area. We have a 13-year-old with a cut on the arm, and you can see here they've tried with. So now we're moving on to more like wounds, and with wounds, it's always important to check that when we're going to suture them, are they contaminated? Do we need to are they in an area where there's going to be a lot of stretch? This is the upper arm, the lateral upper arm, maybe 2/3 down the arm. So the elbow is down here, and the shoulder is up here somewhere. In a 13-year-old. So, and we need to know whether they have tetanus or not as well. But once all of those things are done, and we talked about that, then how do we manage this? Well, it's a 13-year-old. I would probably be able to manage this in a cool 13-year-old. I would be able to manage this as an adult, where you do xylocaine, xylocaine from here and here and here and here. You could try to glue this as well. Maybe it would be okay, but there's a little bit of traction here on the lateral arm. I would think. So, and they tried with Steri-Strips as well in another place before this, and that didn't seem to work. So I would suture this. And all of this it's always a discussion, right? So that's why I'm also doing a lot of cases, because what I'm saying is not the truth. Some would maybe glue this and it might have worked fine, okay? And sometimes the cosmetic result is not as important as the pain induced for the child. So it depends, right? And sometimes just one suture is enough. You don't need to. So everything depends. That's why there's so many factors to play in here. It's so interesting to do this. And these decisions are not necessarily easy. I hope I can try to convey that. So, and if the child is really squeamish, then EMLA could be used here. You could use EMLA and midazolam or virtual reality to kind of get their anxiety levels down. The good thing with virtual reality would be that they didn't have to have a sedated child afterwards. So preferably probably virtual reality. And you can even combine those two, midazolam and virtual reality as well, if they're really squeamish, or if they're really afraid. But in this case, I did EMLA. Oh, sorry, I didn't do EMLA because it was kind of in a hurry. So they wanted to get home, so we didn't do EMLA. I just did xylocaine injections, and it went well. Okay, moving on to another classical wound. Here's a around 6-year-old who had this wound after falling and hitting her head on the kitchen table. And this, like, when we examine these, I usually, it's a good idea to just, with the parents' consent, take the picture, because then you can discuss it with your colleagues, and how to manage it best, because you can try to describe wounds in a lot of ways, but it's always about, like, a picture says more than 1,000 words here. So how would you go about managing this? Because it is something that needs to be put together right. It's a suture or a gluing this. The eyes are right down here, so having the eyes so close is always a bit of a concern when you have glue. So at least if you would glue this, you'll have to put the child down in a horizontal position, maybe even with a slightly extended head, so that if the glue runs, it runs upwards and not downwards. You will have to cover the eye either with bandages or as I showed, with a tegaderm. You could do that as well. And this would probably be able to be glued. And knowing what I know now, we probably could have glued this as well, right? So, but I think in this case, what we did was there was a lot of anxiety. There was a lot of long wait time for them as well, and we did. This is one of the situations where it was more not so minimal approach, but more full on because of the anxiety. So we did nitrous oxide, because I believe that the patient here was really afraid of needles as well. So we did nitrous oxide. I came from behind because that's important to don't show the instruments to the children if you don't need to. And so come from behind, and then during nitrous oxide, we do lat gel, and then we do nitrous oxide. So lat gel for 20 minutes, and then we do nitrous oxide, and then you can either do it with local or without local after the lat gel. But here I managed to do it without any local. And you have to work kind of effectively and quickly when you're suturing these. And sometimes you don't get all the stitches in that you want, but 2 are enough, and you can do the rest of with Steri-strips or glue, right? Yeah. Okay, wound on the chin of a 14-year-old. So here is a wound that is a bit contaminated as well. So here's important to get a good tranquilization so that we can clean up the wound as we do with all wounds, but especially here, and then we'll suture it. And always think about whether there's a fracture in the chin when they have these injuries. Yeah. Then we have another kind of wound / abscess. 14-year-old with a pilonidal abscess. And this is a classical pilonidal abscess. What to do with these? Well, in general, they hurt. And I know in the adult emergency department, we would usually just do a quick stab and then it's done with. It's a quick procedure where we empty it out, because they are almost impossible to pain manage, because You can tranquilize with xylocaine the top of like the skin here, but going down, you can like if you push any fluid into this hole, it'll just hurt more. So you can tranquilize the skin, but it's always quite hard to do. Um, I usually try just to, where I want to cut. I'll tranquilize the roof, and then I'll do the cut. And the cut should oftentimes they usually talk about it being on the lateral aspect instead of in the middle. There's so much tradition in these abscesses, and EM cases have done a great podcast on abscesses management as well. Whether or not you should put anything in them, like a glove, or like do something more sophisticated. As I believe, there's probably a lot of nuance that I don't know, but there's not much evidence here to say that you can manage it. You could just, the most important thing seems to get a hole in it. If it's fluctuating, then get a hole in it. Tell the patient that it might come back, and once you're in there, try to get as much stuff out as possible, all the lacunes. And that's a problem, right, in the emergency department, because these hurt. You try as long as you can, and sometimes they come back, sometimes they don't. And if they come back, then they probably have to go to the OR to get a decent management, like, or not a decent management, but a better, more thorough cleanup of the area. And even then, there's a higher residual risk, right, for them coming back. But how do we manage the pain? So the pain in this case, we could manage with nitrous oxide. We probably should do that in adults as well, right? Or midazolam and virtual reality could also be a way to do it. And then try to maybe put because the skin, like we use EMLA when the skin is not broken, and we do use Lat-Gel or Amnitop when the skin is broken. So here the skin is not broken, so EMLA over this area. You could also use just local xylocaine, and once we're about to do the jab, then do it quickly and have the nitrous oxide on max at that point. And remember, nitrous oxide, Dextor, and such drugs, virtual reality, they don't have any inherent pain reduction in them. Some like virtual reality have some hypnosis, but Dextor has no pain reduction, but it will potentiate any other pain medication. So always a base of paracetamol and NSAIDs could be a good choice here as well. Okay, so here we have a 3-month-old with an abscess. And this is harder to see, right? This is not as skärmogen eller skärmoden, or it was fluctuating a bit. And the question is whether this should be managed with anything else than the expectation, and maybe antibiotics. I found that a lot of the surgeons actually used antibiotics much more than we use in adults for these children with abscesses, if they were not able to cut them. And the main thing here is pain management. I believe this child also had a bit of fever, so it's important for such a small child to pain manage, to give something so to make sure that they are eating and drinking and peeing and all of those like normal homeostasis things. And if they and then do a follow-up, because this has to be managed. I believe this child couldn't sit, and this has to be managed so that it will go away in at least a few days or a week, right? So that the child can continue developing normally, and would be without pain. So not everything has to be managed with sedation. All right, a 14-year-old with an abscess here as well. It's probably not a pilonidal. It's probably more of an abscess. And the extent of this was quite big, and here the surgeons called for actually operation here, but it could probably have been managed locally as well. Why they decided to do operation on this one and not the pilonidal, I am not sure. And that is, sometimes you have to ask your surgeons about like the management of these, especially the pure anal abscesses, because they are like, if you have the anus down here, then of course what we always want to be, what we are afraid of is what you call pure anal sepsis, right? So if you have infections that go through fistulas and into the soft tissue here, then usually you have small, like they're usually not that prominent, less prominent, very like when you push down hard, then they're tender areas, and usually they have fever. I only see this in adults, the perianal abscess, with fistulas and so on. That's what we don't want to cut in. Even though I know in some North American emergency departments they do cut in those, but usually we manage them with MRI or CT to like see how extended they are, because they can be quite extensive and they have to be managed in the OR. These, and then you have the pilonidals, usually in the midline or around the midline. And then you have these on this is a gray area, but I think it's a normal abscess. And then these are like usually somewhere on the buttocks, and they could be managed just like any other abscess, right? There's lots of other anal problems like prolapse, like a skin hematoma, or what they called, I can't remember, really painful. And there's these fissures, and there's a great EMU 365 video on those. I don't have the reference here, but it's really, really good, and you can check that out for more on the management. Good. Oh yeah, I managed to put it in the slides here. So here's the reference: Management of Anorectal Problems in the Emergency Department by Stan Feinberg, on the Vimeo, and it's on the EMU 365 homepage on Vimeo to find it, if you can find it on the homepage here or by Googling this. All right, so then we have a 5-year-old with a hand burn. And how would we manage this if it came into my apartment? Well, we would probably manage this with, first of all, burn wounds, as we said, is always intranasal fentanyl. You don't necessarily need to put in a line, a peripheral venous line, peripheral venous catheter on them. That's why we use intranasal. And then you have silocaine compresses around this, around the burn. And then you have to consider whether the burn is very extensive, like I think it's more than 15% maybe, or if it's a circumferential area, like, or circumferential burn, or if it's a very sensitive area, like the head or the genitals. And if they have none of those features, right? So then it's like, if it's not an extensive one, if it's not a really small child with and it's not a in the face or in the genitals, and it's not circumferential, so that it will not squeeze or become ischemic, then it's kind of what to do with them. Well, they need to be cleaned. The blisters, if they are in the way, like Justin Morganson have gone through the evidence on the blisters, there are no evidence, no consensus on that, despite something that there's a lot of meaning, a lot of opinions about. All right, but in general, blisters, a mechanistic argument would be that if they're in the way, then they should be taken away, right? If they're hindering function, then they should be taken away. If they are at high risk of being like getting destroyed themselves through activity, then probably you should de-roof them or put a hole in them, because then you can do it in a sterile environment, and then they don't have to there's a lower risk of sepsis. Like that's the argument at least, or lower risk of an infection developing. So, but here there's not really any blisters, but it has to be cleaned, right? What they have, I believe this is mepitil that they put in here. And what to do with this? Well, this would probably hurt so much to remove that I would have to take it to ask the surgeon to take it to the OR and clean it. If it had to be cleaned in the emergency department, I'm not sure that intranasal fentanyl and xylocaine compresses could tranquilize the patient enough. Maybe you could add ketamine as well. So you have morphine and ketamine. That could be done. If it's a bigger child, then it will be per oral ketamine, like in a juice box. Yeah, but it depends, and you have to see how much it hurts, or if it doesn't hurt that much, maybe you could give it a try, and then you can go to OR if it doesn't work. So you have a plan A and a plan B. Yeah. Then another one here. Day 2 of a burned hand. The primary care physician has sent this patient in because there wasn't. It was too painful to remove the gauze, because the burn wounds will stick, or the gauze will stick to the burn wounds. That's why you have to put mepitil on it, so that they don't stick. But it hurts the first time that they have to remove these, right? So, and they have to clean it, and usually we do follow up within 3 days. And if it's a weekend, then they have to come back to the emergency department to get that first wound check. So here again, it's intranasal fentanyl to be able to do this, and always with paracetamol. Like if it can be planned, like here, then always paracetamol and ibuprofen 1 or 2 hours before. And I forgot to mention, if it's a fresh burn wound, of course, 20 minutes of water, and see to it that they don't get cold. It doesn't have to be water, it can be any kind of fluid, as long as it's neutral pH wise. I've had patients who have, there was a craze at one point in Copenhagen where they would take acid, and some random attackers would spray acid into the face of some bystanders, usually drug related behavior, and drug war related behavior. And at that point we were told by the eye doctors that any kind of fluid would be okay, both for burns, but also especially for the eyes. So any kind of fluid, whether it be soda or it just has to be neutral. So yeah, any fluid is better than no fluid. Okay, burn wounds. This is the general management here. They also, in the Swedish one, if it's more than 5%, they say, or a very sensitive area like genitalia, consider talking with a surgeon. Yeah, but it's only when the wounds become, I think, more than 10 to 20 total body surface area, that we think about moving these patients to another place. In Sweden it's Uppsala and Linköping, and I believe maybe Umeå, that are the burn centers where you do modified Parkland formula, you give you fluids and all of those things. But it does happen, but it's rare that it has to be really big for them to take it. All right. And then, of course, all burns are always all burns are traumas until proven otherwise. and so on and so forth. But if it's a good history, like it's more like with adults, but with children, it's usually not that complicated. It's usually boiling water, sadly. So remove all boiling water from at home if you can, because these children usually are really hurt. Yeah. So paracetamol and ibuprofen compresses with xylocaine, and then let it work for 20 or 30 minutes, and then intranasal fentanyl. And then if that doesn't work, then you do nitrous oxide and maybe L-fentanyl, and then you can use esketamine as or more sophisticated stuff. Yeah. All right. Another chin wound. Here, this is a good one for lat gel. And if you don't have lat gel, then you will use then you probably use a small dose of midazolam and then EMLA, and then you can xylocaine in that area, local xylocaine. Yeah, and lat gel, because if you have lat gel, then usually you would have to do it with a small amount of or you have to do it with Dextor so that they don't move around with these small children, but depends, right? Maybe this is a bit of a complex suture. You might need a suture here and here. I would probably first place this here and then try to adapt this one and then see how it looks after that. This could probably be done with Steri-Strips, and this one probably with Steri-Strips. So mainly here and here. And I'm sure there is some traction here, so you could do it with a different technique, like a horizontal mattress maybe. But I think like just simple sutures here would probably be good. But I'm no guru in suturing, so check out the other resources for more sophisticated methods. Okay, here we have a lip wound on a child. And if this child came into our department, we would probably, with lip wounds, it's always important to, it has to be perfect, right? So the first suture that you do has to be good, so that the red of the lip is in continuation with each other here. So the first suture has to be perfect. Here I would probably do lat gel. It's a small child, so lat gel. And probably with ketamine or Dextor, and then I would do suturing. Yeah. Here is a forehead wound on a 5-year-old. Here, again, if the 5-year-old is quite cool, then lat gel and nothing else would probably be good. And then coming from behind and then doing stitches. And that's what we did that's what we did in this case as well. Another forehead wound on a 5-year-old. Again, this could need suturing, could also need gluing, and the same thing with the one that we just saw. It could have been glued maybe as well. Depends, right? So when you decide whether or not to glue, you can try to like push on the edges and see if it comes together nicely. And when you glue, you put a bit of like you get the glue, you put a bit of glue in, and then you push, and then you push here, and then usually you use with Steri-Strips afterwards as well. Yeah, I would probably glue this and try. Okay, so here's a forehead wound 5 days after suturing, where the stitches have been removed at the primary care physician, but the wound looked not healed. And I agree, the wound doesn't look healed. It looks like there might be some secondary infection maybe going on. There's a bit of a yellow crusting here, and it's in an area where, like with the eyebrow here, it's in an area where you want it to be a good cosmetic results, and I'm not sure whether this would, I don't think this would get a good cosmetic result. So this would probably be discussed with our with a surgeon. In this case, at least in Stockholm, in the face, it would be a ear, nose, and throat for children. So an ear, nose, and throat surgeon, and it will have to evaluate whether it should be operated on or not. Here is a 4-year-old with a scalp wound. This is an excellent wound. If you dry it off, you'll see that it has a bit of a glitch, or it's gaping. And this is a excellent wound for hat, like a hair, the hair technique there, where you. So I'll take a bit of hair here and twist it around, maybe wet it a little bit, and then cross it, and then cross it again, and then put glue, and then pull tight, and then put glue into it. And they don't shower for two days, and then and don't be too rough on the wound, and then usually the crusts will fall off, and the wound maybe after a few days will be gone. So in the scalp, I think I can't remember, maybe it's 7 to 10 days where the stitches have to sit there. So around that time, they should be more careful with their wound, and then after that, it will be all right. So here's the guideline on wounds in general. So consider paracetamol and ibuprofen. Yeah, that's we done, and then do lat gel. But maybe you can add lidocaine. You can also do compresses with lidocaine only. That's also an option instead of lat gel. I've never used that, but probably it's also an option. And then you can use Dextor if need be. If it's a child that is more than 3 years old, you can use nitrous oxide, or you can combine. And that's the thing we haven't talked too much about, because when we were working, it has to be in the daytime, and usually I worked night times as well, so I couldn't always do all the things that were optional, because we were not allowed to use Dextor and ketamine together without a superior or senior at the place, and there was no seniors during the nighttime. So, but you can do that, and then you get both the sleepiness and you get the pain reduction. Again, you will have to reduce the doses of Dextor and ketamine if you use them together, and only 1 milliliter in every nostril. And yeah, and then plan C is usually intravenous ketamine. I have done that a few times, but always with a specialist doing it. Yeah. And the lat gel, well, the wounds have to be less than 5 centimeters. So if you give these, we had one case where you have a girl coming in who punched through a window, where there was cuts all the way through the arm, and maybe there was glass somewhere, and that's a case where we should not. We could probably tranquilize all the wounds and then suture it, but it's you need to explore the wounds to see if there's glass, and at least it's a discussion with the orthopedic surgeon, I would say. And also some of the wounds were really close to arterial arteries. So if one of these patients come in, and then the first thing I would do is to get a tourniquet if there's bleeding, because usually they will come in with bleeding. So I'll use a tourniquet or a blood pressure cuff, and then use it as a tourniquet. And then I would until the bleeding stops, and then I would explore the most bleeding wounds as I'm releasing tension on the tourniquet, and then seeing whether it bleeds arterial wise or not, and see where it bleeds, and see if I can see if it's an arterial bleed, then usually like almost all bleeds stop with compression, right? But if it is an arterial, like a big arterial bleed, then I will have to have a surgeon come down immediately to either take care of it or yeah, go to the OR. Okay. Wound info in general. So for glue or hat techniques, it will peel off within 7 or 14 days. Keep dry for 24 hours. Don't soak for 7 days. For steri strips, keep until they fall off. Keep them clean if they can. Stitches, remove with primary care if they're resorbable. If they're non-resorbable, if they're non-resorbable, but if they are resorbable, then you just they have to resorb by themselves. All should get the information that return if infected or opening a lot, right? And usually we'll get them steri strips home to, like, if one stitch goes up, then maybe if one stitch comes loose, then you will just use steri strips. You can use like antibiotics is usually not something that you need to do unless there's an open fracture, and that means I've done a video on what it means to have an open fracture, especially Gustilo-Anderson type 1, where it's just a small hole in. It has to be in the vicinity of the fracture that the hole is. Like it has to be the mechanism has to be that the bone has gone out through the skin, and then maybe come back in, and then that's why there's a hole. So mechanically, it has to make sense that that hole has been made by one of those things. And that's from my understanding. But I have heard some who would say, like, any hole in the vicinity of a fracture, no matter whether the mechanism is that it's gone out or not, should get antibiotics. So I'm not quite sure. I'm like the aforementioned ones. The first ones, yes, always. The second ones, probably not. But it depends on where it is. Ask your orthopedic surgeons if you're in doubt. Then some bite wounds, especially human bite wounds. There's a lot of controversy around dog bite wounds. Justin Morgenstern would say no. There's no evidence for treating them. Some orthopedic surgeons I've talked with have seen wounds that got infected, and I'm not sure it would have helped with antibiotics anyway. But they usually say, like, if you've seen the wounds that do get infected, they always give the antibiotics, even if it's 1,000 or 100 people who needs to get antibiotics in vain. I'm not so sure, but the immunocompromised, at least always, yeah. And whether it's contaminated or a late presenter, you can close it, but then always consider using antibiotics. Again, check out Justin Morgenstern's his laceration series, where he says, like, you can close the wounds after X amount of hours, especially if they're big. The thing about they can get infected and all is probably really a weak mechanistic explanation, and he argues that it doesn't make sense. But he would usually ask patients, well, if you want it to be closed, then I can do that, no problem. I would do it myself if it was my wound, but we would consider getting you antibiotics then, just to give you a bit more protection. Should the wounds get wet or not? It's controversial. You can gently clean it with neutral soap and that damp cloth, maybe 1 time per day. And others say it has to be dry for 5 days. There's very much controversy here. Don't scratch it, at least. And if you swim, can you swim with it? Well, that's also controversial, but at least you can use tap water. That's okay for cleaning. Swimming is probably quite low risk, especially if you have a watertight bandage. I looked up the evidence for this earlier this year, and the evidence is really, really weak. And the good thing here is that you can use tap water to clean your wounds. There's, at least if you live in a country where it's a good tap water, right? And it's important to say to the patients, there will be a scar. Healing takes at least 12 months. And if they need, healing takes at least 12 months, so it may reduce by that time. So you cannot evaluated before or after 12 months. And there's some light advice that you can use some ointments, keep out of the sun, and so on. The evidence here is also a bit mixed, as I'm recalling, but yeah, I usually say this to patients. But there will be a scar. It's really important to tell them we are approximating the line, like the skin, so that it will heal the best way it can, and without risk of with less risk of infection, I guess. But the main thing is that it heals well, and some people just scar more than others as well. So it depends. So but parents are very oftentimes very concerned with their children, and they want to, like, it's important that they know that there will be a scar. It's not our doing. Okay, and here's the wound care glue from these references. So avoid touching for 24 hours. The overall appearance can best be described as resembling a dry scab, and it should be treated like a scab. Do not pick in it. Keep dry for at least 48 to 72 hours. Avoid excessive movement on the area, especially during the first couple of days. Whereas likely of continued trauma, you should use a clean, dry dressing to cover the wound site. Avoid sticky plasters. Avoid over glue, and remove soiled wet dressing. Yeah, the adhesive will come away from the skin on its own in around 10 days, just like a normal scab. By this time, the wound should be sufficiently healed. In areas where the skin stretches, such as over joints, a wound tape should be applied for further 3 weeks, and so on. And it has the same, that's really important, it has the same, like Justin Morgenstern says the same thing when he's gone through the evidence. He uses glue all the time on almost everyone, if he can. So the cosmetic result is the same. Okay, moving a bit more into fractures. And I've already used some of the guidelines here, but this is the guideline book that I'm taking the treatments from with fractures. It's Barnfraktur og luxation i öppen vård from 2024 from Astrid Lindgren, and this is open source. You can find it yourself if you want to. And they also have a entire book called Barnkirurgi eller barnortopedi on Astrid Lindgren's sjukhus, where they also have like more details about these. But this is more like a cookbook. Okay, so in general, we talked about with fractures that you have an injury, and you believe that there is a fracture. There's a high there's a high precise probability of a fracture, but even though the X-ray is normal. This is especially with the elbow fractures. There might be minimal or just indirect signs, or only clinical signs. And in general, as a rule of thumb, if you have a child who doesn't use their arm and there's just like clinical swelling in their elbow, I would use a cast there, and then do a follow-up in 1 week, and then a new X-ray, and then they can check out whether it's that or not. Always think about the mechanism. If it's a child who has been drawn in their arm, then it might be a luxation of the radial head, nursemaid's elbow, I think it's called. Yeah, and then but usually they don't swell up. It's almost only fractures that swell up like that. So just to remember, if you might have a negative X-ray, but the precise probability for either read wrong or a fracture that is not possible to see on the X-ray, could be like a scaphoid fracture or some of the bones in the hands as well, or Lisfranc fracture as well. So you believe there is a fracture. Then are there any complications for that fracture? Well, if there are, and the complications are usually dislocation, it's compartment syndrome, open fractures, or neurovascular compromise, or NAE, non-accidental injuries. Like it's part of the scared off, right? But the septic one is not. Like the septic one is non-traumatic usually, and so on. So if you have the traumatic part of the scared off, do you have any of the complications? If not, then are the accessibility criteria, likelihood for healing and so on, likelihood for healing well, are they there? And the acceptability criteria, that's what the cookbook is for, depending on the area. But as a rule of thumb, you would say we accept a lot if the fracture is in the magical metaphysis, because it will grow to normal after a little while, and especially if the child is young, because then they have a long time to grow and long time to normalize. If the child is not that old, then the if the child is older and it's in the diaphysis, then the diaphysis doesn't grow. It just stays how it is. It's not magical at all. So fractures in the diaphysis is almost like adult fractures. You don't accept that much angulation here. And also even metaphysis fractures that are in a child that is almost grown up and is not growing too much more, then there's not a lot of time to grow into the fracture or grow normal again. So as a rule of thumb, metaphysis and young age, then you accept a lot more than diaphysis and high age, right? And then we have these three pathways, right? So the conservative management, as we talked about, well, if it's conservative management, meaning that the criteria of acceptability is okay, then it's, and there's no, like, the pain is like, for conservative management, it has to be acceptable. You also have to have pain management, so that it's acceptable pain management, and the place that is doing it has to be able to do a decent cast. These three criteria: cast, pain management, and acceptability criteria. And then in parentheses, no complications, but that's the fourth criteria, I guess. Then you can do conservative management. And usually conservative management is X-ray or doctor follow-up within 1 week, usually 1 week ahead. Pain management usually you don't need that much pain management for most of the fractures if you get a good cast. Then you have to get the cast info, and the cast info is usually don't get, like, depending on what kind of cast you have, if it's a plastic cast or it's a normal cast. If it's a normal cast, then it's usually don't get it wet within 24 hours. Come back if there's neurovascular compromise or if there's a lot of pain, like pain out of proportion suddenly. Don't shower, don't get it wet at all. You have to shower with a bag over it. The 24 hours is usually it's setting. The cast is setting within, like, the first 24 hours. So if it's still setting, you should be extra careful the first 24 hours because it might break. That's usually the information that we'll give. And then I also tell them that everything that is not cast you have to use, otherwise you will lose it. Children don't lose it as much as adults. Children usually use their arms and legs really, they will not be stiff as much as us adults will. But still, I will tell them to mobilize all the limbs that are not immobilized. Then usually activity information, they should be able to, should get the information that you cannot do high risk activity for the amount of time that you have to cast, which is usually 4 to 6 hours, 4 to 6 weeks, or 3 to 6 weeks. Usually 4 is the median, but sometimes less, sometimes more. You cannot do high risk activities during that time, and usually 2 or 3 weeks after that. And then they should know that if the child falls in the same way, then the fracture is, like, where there was a fracture is still the weakest link in the chain, so it might do a refracture there. And that's why the risk goes down after a couple of weeks after it's healed. But if it's a sufficient trauma, there will still be a risk of a refracture. And there's no way to prepare for that, to that not be a thing that is going to happen. So they should just, after the high risk period is over, they should just do what they do as normal. And they should keep their arm off, to reduce swelling. They should be informed about the hematoma that might be created if for instance have a hematoma, like if they have a fracture of their hand or arm, then usually if they keep their arm up a lot, then they will get a blue elbow, and that's not a problem if it doesn't hurt. And red flags to return, infection, and well, all of these risk factors, right? But especially neurovascular compromise in the cast, or infection, or pain out of proportion. So that's usually the information I'll give them. Then, so back to the fracture, there's no complications. Is it acceptable? No. Then there's an intervention to improve. Either we ask orthopedics, like in the hospital I work at, we have a list where we can just ask them the day after, so that we don't have to wake them up during the night. Or you can make the decision yourself whether to reduce it or not. And usually reductions cannot be done during the night, or it can, but it's a bit resource intense and has to be planned. So usually they'll go home with this management, and then they'll have to come back and be told that they need an intervention where we try to avoid operation by reducing it closed. And yeah, if they do have any complication, that's also an intervention. So here are the two other pathways. So the conservative pathway, then of course open reduction during operation. That's usually if you have these complications, or if it's a really complicated fracture, or if they have a high amount of pain so that it cannot be managed. And then you have the close reduction, and that's always an attempt, and we have to think about timing of it. So the timing of this, like we usually said, a fracture has to be reduced within 5 days, something like that. And yeah, so if you're on day 4 or day 3, they've arrived late, then you have a bit of a problem. Some fractures are less painful and they seek late. You always have to be aware of non-accidental injury, not NAI, sorry. You have to be aware of that. But if there's no such concern and they present late, then sometimes there's nothing to do than just like you can, if you're beyond the 5 or 7 days, something like that, then you have to be managed conservatively. And then if it's there and if there's a big misalignment, then they have to be operated on a later time. Okay. If you postpone their treatment, so yes, there's have to be an intervention. No, you cannot do it today, but you can come back to one of the other days to do an attempt at a close reduction. Then they have to be pain managed. They would have to have no complications. That was the fourth criteria. Like they have to have a cast. That is good, and they also have to have like geography that or logistics that allows it, right? Then you can send them home. And yes, to all, then book the time. They have to have EMLAs on 1 hour before, so they have to have EMLA with them. They have to get NSAIDs and paracetamol before, and then have to be fasting for 4 hours before as well, because if you are giving them deep sedation like L-fentanyl or something like that, then it's important that they haven't eaten. But if you know that you're not going to do that, then they don't have to fast. Okay. If this close reduction fails, then of course you have to do it openly during surgery. If it succeeds, then you go back to this pathway. So this is the workup that I do, and I tell the patients about. And of course, there's a pathway up here where if you have injury and there's no fracture, but there might be the other things like complicated operative soft tissue, including big wounds, then you also follow this pathway down here. You have to do an intervention. It's not a reduction, but it's usually an operation that needs then. So that's enough about fractures in general. Let's look at some fractures here. So here's a 8-year-old with an ulnar diaphyseal green stick fracture. So here we see both ulna and the radius is off, and the radius a bit more. This is like you have like you can see the arm is like a swan position, dorsally angulated, and the acceptability here, you can see a diaphyseal radius ulnar fracture, both of them. So around, for this one, it's the distal part. So for the middle and distal part in children below 10 years of age, then 15 degrees are accepted. And this is not 15, this is maybe 30. Yeah. So then this one would be booked for, I will check that there's no complications. It doesn't, like, this is not a fracture that seems like an open fracture. There's neurovascularly they're okay. And they're like, usually they'll get a cast and then they're pain managed. And then it'll be sent home with paracetamol, NSAIDs, and maybe clonidine if it's a really painful thing, but usually it's not painful after the cast is on. And usually pain medications only needed during the nighttime. Yeah, and then they come back to reduce it some more. And how I would reduce this, I would probably break it all the way through. Right, this one. So you'll depending on how your hands are, like, but you'll have to. I'll have my one thumb here and another thumb here, so I'll hold it just like a stick with my hands here, and then I will push it all the way down until I hear a click or a snap, meaning that I've snapped it all the way through, and then I'll reduce it to normal. But before I do that, I have to. That hurts, right? So I have to do this stepwise approach that I told you about earlier on. So this is probably going to hurt so much that I need alfentanil for this. So the setup would either be an axial blockade of the arm or alfentanil and a local blockade. So with virtual reality or a nitric oxide. Usually nitric oxide is what we would use. So the setup would be two anesthesiologists and or at our hospital it would be an anesthesiologist and an anesthesiology assistant, and then me, and then a nurse for the casting, and then maybe someone with me to check that I'm doing a good job, depending on how experienced I am. So step one is they have EMLA, they have paracetamol in their body, they have ibuprofen in their body, they've been fasting. Okay, good. If they've been doing all those things, then we will put in a peripheral venous catheter, and we will do once the peripheral venous catheter is in, then at a specific time, like maybe 9 o'clock or 10 o'clock, we will go in, the entire team, do a sign in, knowing what kind of procedure we're going to do, and what kind of tranquilization we're going to do, and what steps we're doing to pain manage. So, and once that has been done, we will the anesthesiologist will start to use nitric oxide, and I will remove the cast once the patient is out of it. And maybe some anesthesiologists will at this point also give a little bit of alfentanil. It's a really, really quickly reacting drug, right? So it'll be quick in and quick out. And I'll remove the cast. I'll hold the patient's hand, and I'll use ultrasound to check where the fracture is. Usually you can see this thing, you can see the fracture line, and I'll mark this area on the body with a pen. And once I've marked it with a permanent marker, then I know where to give the injection of xylocaine. I've measured how much xylocaine I can give, 4 milligrams per kilo. So once I've done that, now we haven't given the xylocaine yet. So I'll give the go signal for, like, I'm ready for giving xylocaine, and then they will give more alfentanil, and then I will first slowly advance the needle a little bit, give a little bit, and then advance the needle all the way down and try to find if I can find a. I will try to see if I can get a flashback. I don't always get a flashback. I almost always do, but not always, especially with these green stick where there's not a lot of there's not a big wound here. So I won't always get a blood flashback in the needle, but I will and always, if you get a flashback, and when you get a flashback, make sure that it's not pulsating, right? That you didn't hit a vessel. But you go down, and then you'll tranquilize the periosteum, and then try to get most of it in the wound and around the wound, and then out, and then I'll do it on the other side again as well. If it's a minor fracture here, I won't do it. But if it's a bigger fracture like here, or like a moderate size fracture, I'll do it. Then we wait 10 minutes. Nitrous oxide is off because they might vomit the longer they have it. So nitrous oxide is off, alphentanil is off, and we'll just speak with the kid. During the nitrous oxide, usually they are trying, they use some kind of distracting method. Either they will tell a fantasy story where they go on a split splash or something like that, what the child likes to do, and they go on a journey, like a mental journey, like let's go into this place and let's go into that place, and oh, are you going to jump? Yeah, I'm going to jump, and so on, right? Following them, like guiding them through like a ayahuasca kind of thing, and usually the children at this point, once the arm is tranquilized and they're using nitrous oxide again, then oftentimes I've seen the child just using the broken arm, and then we have to tell them not to use the broken arm. But at this point, we're waiting 10 minutes. They're off the drugs, and we're waiting for this to work. And then I come in after 10 minutes, or I stay, and I am there after 10 minutes. And I've already told the parents that I'm going to break the arm, and because it's a bit traumatic for them, so I'm telling them that beforehand what I'm doing. Okay, so now when it's like 8 minutes, then after I've given the injection, they will begin to give more Luscos or nitric oxide, up to 50%, and then once they're out of it, or not out of it, but once they're tripping, then, or hypnotized, or what you dissociated, then we will give alphentanil as well. And once the alphentanil is working after a few seconds to minutes, to maybe half a minute, then I will begin reducing. And the reduction, even though we do all of this for big fractures, it does hurt. And so I will grab the arm here and here, and then I'll break it. And quite a lot of force for this. So you break the hand down that way in that direction, and then up again. And you will do it until you hear the. That's because it's a green stick fracture. That will do that. Okay, and after that, we once we are satisfied, we will check with ultrasound. Usually clinically you can see it, but we'll check with ultrasound and see that, oh, it is actually aligned now. Good. Then I will hold it, and then comes the fight with the nurse. We've already prepared what kind of cast they need. They need a high cast here, 90 degrees flexion. Okay, and so now I'm trying to hold the fracture, and here the fracture wants to go this way because that's the way it was broken, right? So I'll have maybe a bit of traction. Usually traction just helps, but sometimes you have to hold it with your thumb and your index finger, and that's a problem when you're. Usually these sits quite okay. Some fractures will glide, and if they do glide or they do displace, then it's a sign of, well, it's going to do that in the next couple of days anyway. So it's an operation that is needed actually. But you do your best, and usually traction is the best way, both to hold the fracture and also not get in the way of the cast nurse. Once it's cast, then I'll let the drugs go out of the body. Both alphentanil and nitrous oxide has a low, they have a quick half time. So after a few minutes, they're back, and once they're back, I will send them for X-ray. If it's ketamine, I'll have to wait for a little bit until they're okay, and then I can send them. And here's the results from this one afterwards. It's rotated, but yeah, we here I managed to align it totally, almost to an anatomical normal position, and that was not always the case, but this is one of them. Okay, next case is a 10-year-old who's fallen from a swing and twisted his leg. And the leg was obviously misaligned. So first things first, neurovascular status, distal neurovasculature, is it okay? And this is a fracture also that might have a really sharp fracture. So high risk of this being an open fracture. So we have to check that. And then it's but before we can check anything, we need to pain relief. And sometimes when these patients come in, even if it's obvious, sometimes because of all the commotion pre-hospitally and getting the patient from the ground to the ambulance and so on, they don't necessarily examine them that much. So the pain area of the pain could be anywhere in the leg, right? So you have to, when they arrive at the hospital, pain manage them right away. Usually in the ambulance here in Stockholm, they will be getting intranasal fentanyl. And if they haven't already, then you'll get 40 milligrams per kilo of paracetamol. And don't give them NSAIDs because this is an operative thing. They have to be operated on soon, within the next at least 24 hours. But you can give them clonidine as well. How do we manage the pain otherwise? I mean, there are other things we can do, but that will take a while. And what we want is an X-ray quickly to see what is what here. So if the neurovasculature is okay and the period and there's no through sticks, or like it's not an open fracture, which is hard to assess because lifting up this leg to check beneath is quite hard, right? So, but you do what you can, and oftentimes they will have, maybe not with this kind of fracture, but with other fractures, they would already have put on a small cast, like a stabilizing cast, and then you haven't been able to see whether there was a intact skin or not. So you need to make sure before they put on even the quick cast that actually there wasn't any through things putting through. In this case, you will, when they arrive in the hospital, probably go and get a intravenous, do EMLA on them. So what I would think it will do, if this patient arrived at our hospital, then we would do. So they've already gotten intranasal fentanyl. I would give them Alvedone, high dose, like 40 milligram, like loading dose of Alvedone. I would put on EMLA so that we can get a peripheral line on them. If it's a big child, maybe we don't need to wait for EMLA. If they're in great pain from this side, then probably we should just get in the peripheral catheter and then give morphine and clonidine. And this should probably take much of the pain. But what we actually want to do once we have the X-ray is that we want to stretch this. Right, so this is a proximal, it's a diaphyseal femur fracture. And these fractures need to be treated with stretching. So we need what is called in Swedish it's called a hara. I can't remember what the Danish or English name is, but you will have to stretch this so that it's aligned. And for you to be able to do that, you need to pain manage the child with the things that I just said. And men even also do a local, like a regional blockade, regional block, a femoral blockade or similar. And then you will admit them. Okay, next case here. A 6-year-old who fuses fall on outstretched hands. And has an obvious misaligned fracture. Usually when you see how they look, it's like they're really like, it's not always obvious where it is, but their elbow is hurting and there's obvious misalignment. And then it's often like, you can see often swelling and such on the humerus. And well, you kind of do an x-ray of the elbow, and when it's this misaligned, you'll usually catch it. What you need to be aware of when you're doing this tactic, where you don't do the projections, you just do an x-ray to see what is what, is that sometimes you with the antebrachial fractures, if there's only one fracture and not two, then the ring, like this Kanzeke ring, or this ring has not been broken, and it must be broken 2 places. So if you only see one fracture, then you always have to check if there is a Galeazzi or a Montecchia fracture. You always have to, that's why I always do an x-ray above, one joint above or one below. And it's a common miss. But in this case, we don't, this is the fracture that we're looking for. There's no risk of any other things. So when they come in, you'll get them, again, paracetamol, clonidine, maybe morphine intravenous, less as before. And these you have to check for neurovasculature very carefully. And I had one patient who had, I couldn't feel a pulse, and his heart, like it's, usually they have a cast in the entire arm, so you have to like pull down the cast to be able to feel the radial pulse. So neurovasculature, they might have intact capillary refill time, like below 2, and they can move their hand and they can feel their hand. So when you say close your eyes and then say which finger am I touching, they can say that. But once, but they might not have a radial pulse, and that could be because of spasm. But if they don't have a radial pulse, that's like something, that's a warning, that's a big warning sign, right? So you have to call the orthopedics right away. And a similar patients to this one had no pulse that I could feel. I had to pull up the cast and actually kind of get the cast kind of, I didn't destroy the cast, but I had to like pull it up really far because I couldn't be sure that there was one. So I used POCUS and I found the radial artery and there was no pulse on Doppler. So we called for orthopedics, and they came down right away, and they tried to. There was a lot to do at that time, so they couldn't take her to OR right away, but she was on the list, and I can remember like if for this particular case there was also a motor and neuro deficit as well, so she couldn't move her hand, she couldn't feel that I was touching her. So at least you can feel some of the fingers at least. So so this was a case where we really want to get her to OR. And how fast that has to go, that's something for the orthopedics to decide, right? But within a couple of hours, and if the hand, like now the hands did have normal capillary refill time, but if the hands didn't have that, if they were both like no pulse and no capillary refill time and a motor dysfunction and maybe a pale hand, then it's really worrisome and then it's right away. But if it's only 1 or 2 signs, then maybe there seems to be some perfusion still, and then you can maybe wait. That's kind of what we were told on some of the courses that we had with supracondylar fractures, that it depends on if all signs are present, then it's emergent. If it's some of the signs, and it's acute, but not something that you need to do like right now, but can wait maybe an hour or 2. Yeah. And there's no like, this is nothing that you reduce in the in the emergency department. This is something that has to be done in OR. Okay, here's a 11-year-old who was tackled from behind, has pain out of proportion. So this is one of those where we had to consider compartment syndrome right away. So pain out of proportion, how do we do? Well, same management as before. Paracetamol, clonidine, IV morphine if needed. And then you do an X-ray, just to you get the patient into a cast, and then you do an X-ray, and you do an X-ray just to see that that everything is all right, and then you can always do more nuanced X-rays afterwards and do a more nuanced exam. And you check for distal neurovasculature, and you check for through open fractures. And in this case, the only thing that was found was this, an avulsion of the tuberosus tibia. And if there's more than 3 millimeters, then that's borderline for operation. And these are also important because they can have compartment syndrome. So really important to check for compartment syndrome in these. And there's no real there's no real way to check for this. It's observation, and it's like if they don't get better on pain medication and there is pain out of proportion, then you have to open up them, right? So that's an orthopedics decision. What we did we did pain management. We tried to elevate the leg and see if the swelling went down, and by that maybe the pain will go down. But yeah, usually you have to admit these patients for follow-up and see whether or not they are hurting. Whether or not they're having pain out of proportion all through the night or through the day. And if they do, then you will have to pull the trigger on the operation. All right, here we have a 8-year-old high-function autistic child with a supracondylar fracture with a pulse. Same thing again, but and this time around, like the fact that the patient is autistic does sometimes make it more difficult, but most of the children, a lot of the children that we meet that are autistic are high functioning, so then it's usually not a bigger problem. If someone who's not moving normally has a fracture like this, if it's a severe autism, then you should think about non-accidental injuries as well, right? If they're not moving usually. But here they are moving, and there was a definite supracondylar fracture. Same management as before. This is an OR case, right? But pain management is, and the only thing I would add, as opposed to the other things that we talked about, is if they have autism, you could give them midazolam, because that would usually calm things down. But you should be aware that some patients could have a paradoxical effect. And I have had some children who had a paradoxical effect on midazolam or diazepam or any other benzodiazepine. So it can be that they have a paradoxical effect. So ask the parents if they have had that before and whether that's a good thing or not to use. Okay, 13-year-old fell and twisted their ankle during sports. Here we have the tibia and the fibula, and we have an obvious fracture through the tibia, distal tibia, and you almost have a fissulisis as well here, right? I'm no radiologist, and especially no pediatric radiologist, but I would say that this line, it should be more space here. So this line looks like there's a fissulisis. And the Salter-Harris, I mean, it doesn't go through this area down here, so it's probably a what you would call a Salter-Harris grade 2, maybe with a fissulisis. But you also see a fracture line. If you zoom in on this, you'll see a fracture line here on the fibula as well. And there's this fork. I don't think this is the right projection. It's not the totally right projection, but it seems like there's something going on here with instability, right? So a fracture here, so it's almost a trimalleolar. And management of that is check distal status and get a cast on them, and if the neurovasculature, like the distal status, is okay, then you will immobilize the leg, keep above the heart, and like to reduce swelling. If it's looking like this, you probably don't have to reduce anything. You don't have to reduce anything, and then it's OR and pain management as before. Okay. Another one, talking about, like, in general, when it comes to the legs, then usually the fractures of the leg are usually not, it's not possible to reduce them in the emergency department unless it's an emergent reduced, like a ankle fracture that is displaced. But if they're not displaced and not an emergency, like then usually it's an OR case if they need to be treated. Most can be treated conservatively, but the ones that don't, that's an OR case. But arms and hands usually can be pain managed in the emergency department, and you can, with the drugs that we talked about earlier, you can get a good result most of the time. Here is a one where it's like borderline whether this will hurt too much to do, and whether it will be too unstable even so. So this is one of these cases that is not totally classical, and I would ask a orthopedic surgeon about this case before doing anything myself. And the thing is, sometimes the orthopedic surgeons will tell you that you should do it, and you have to like kind of know, well, if it's a cool and calm kid with a family that is not nervous and no complications or anything, then maybe you could try this. But I think with this kind of fracture, it might slip anyway. So yeah, I would have to ask an expert on this. But if they think it's okay, then I could probably give it a try. Okay, some quick fire rounds here. So here is another fracture with a this is a volar angulation of, they've written 23 degrees, and again this is diffuse, so it has to be reduced because of this is an unacceptable angulation. There's no complications, so we can reduce this with either, several methods. Like either, like in general, when you reduce these and when you reduce any of these arm fractures, there's two ways, right? Either you go with the alfentanil way, as I showed earlier, or you go with the axial blockade. So you do VR and like EMLA for the peripheral axis. Oh, sorry. So you do a virtual reality. You do axial blockade so that they can't feel their arm. Maybe with some local as well, local hematoma block, depending on how good the axial blockade is. And then you can just pull it. If it's a good axial blockade, you can just pull it. There's no pain associated with it. And then they have to look away when you're doing it. But usually they're in their VR world, so that's all right. So that could be a good way to do this if you have resources for it. Here's one of those fractures that is easily missed. This is pilbåge, like an arrow and bow and arrow fracture, where it's just bending. And sometimes, like when you look at these pictures, it looks like, oh well, it probably should be bending like this, but it shouldn't, and they don't heal that well. So it's really important to catch these. This is not if this has to be reduced, I will always ask orthopedic surgeon how to do it, because it's like, yeah, I haven't actually done these myself. The ones I've had were cases that went elsewhere. Another one very similar to the other one we just saw 2 slides ago. Same management, I would say. And here, a dorsally mesophyseal fracture. The angulation that is accepted here, depending on the age, is around, like, let's say this is probably maybe a 10-year-old, or maybe just slightly below 10 years, maybe. So that would be 30 dorsally or 50 volarly. So this is unacceptable, and we'll have to, but this can be done. This is almost, so in general, when you reduce the fractures of children, the older they are, the more you have to pull, like an adult radius fracture, distal radius fracture, where you pull and then you push it down. But on the younger they are, the more usually they don't have that much muscle, so you don't have to pull that much, and you can usually reduce it just by clicking it down. So, and then before you click it down, try to feel the fracture before, and check it with ultrasound, because then you know before and after what it looks like and what it should be. Yeah. And this is the result after this, after we did this. And I think we did this, this we did in, and here we did a third setup without L-fentanyl, because these fractures are not that painful. It's more painful when there's like the official, but here the metaphyseal, you can do it with a good team of emergency nurses, emergency department nurses, where you do maybe nitric oxide, and then you do local. And once that is going, and you wait 10 minutes, then you can pull, and usually it's without much pain. Usually they will use their hand once you've done that. Like before you reduce it, they will start using their hand, because it's not that painful. As opposed, or it's relatively less painful than the diaphyseal. Here's one that is very very broken, I would say. A diaphyseal fracture that is unacceptably angulated. And let's say if this was an autistic patient, then this would be an OR case. It's a borderline case if it's not. I'm not sure. You could try to do it, but if there's other factors, like it's a very young child, or it's someone with autism or something like that, then probably it would be better just to go to OR. It's always like a discussion point. But yeah, this will hurt, and you need to be able to reduce the pain. And with autistic children, or children with who are less developed or younger, they will have a hard time accepting even the sedation and the treatment here. Yeah, and very much the same thing here. Here you would have to not just reduce it, but you have to break it, probably, because it seems like it's attached still, so it's a green stick fracture. So you have to break this down, and then afterwards they will be alright. And these reduce really easily. Like, it's painful, but they reduce quite easily, these diaphyseal, and that's why they're also quite unstable if you don't get them to align in a good way. Yeah. So take homes for fractures here is look for distal status and pain out of proportion, and you have to take your time. You really have to take your time to check the vascular status. If there's open fractures, then these are the complications that you look for quickly. And then you have something that some of the fractures are really painful, and some of them are less painful. So mesophyseal distal arm are not that painful. They're still painful, but not as painful as at the antebrachium. And the antebrachium has to have more sedation, and more pain analgesia. And here you usually go with alpha-fentanyl and nitrous oxide and so on. Whereas with the distal fractures, usually you don't need the alpha-fentanyl. You need nitrous oxide and maybe a local. Probably something we should do in adults as well, I think. Yeah, and always paracetamol and NSAIDs. NSAIDs when they're not going to the OR, and even if I find that it helped even during. But even if it doesn't help during, then it will help afterwards once the other drugs are, like the local is wearing off. They need pain medication to the first couple of days usually, when you have reduced them. And you get the cast info, and we already talked about the cast info. Yeah. So for reposition, just to show you what the book says. Yeah, paracetamol and ibuprofen 1 to 2 hours before. If you need more advanced pain medication, like an antebrachium fracture, then nitrous oxide, intravenous alpha-fentanyl, and then local injection on the site of the fracture, like a hematoma block. If it's more easier like reductions, then usually only nitrous oxide, like the finger blockade, or like the like the finger fractures that we talked about, or the distal arm fractures, then usually this is enough with just nitrous oxide and local. And if there's no, like, if you like the nitrous oxide, they say they can be replaced with Dextor, and I agree, they can. It's not as good because it will hurt and they will wake up. In my opinion, or in my experience, it hasn't worked that well with Dextor, but it can. I think if the child is big enough, then virtual reality and maybe with or without midazolam could also work. Plan B is sometimes used as a plan A, depending on the resources. For these, both for the, especially for the, I don't know how big how painful they can be, but I suspect you can do operations on patients with a good axial blockade. So I believe that both the very painful and the less painful ones, they can be managed with axial blockade. But I'm no expert in that, and you have to ask others. But I did a few in axial blockades, both antebrachial and distals, and or at least I'm sure that I did the distals. Maybe I did one antebrachial in axial blockade, and they both went really well. So yeah, and of course I have done a few, and it's usually the smaller children who cannot cooperate or cannot do nitrous oxide. They will have to do intravenous ketamine in a almost like operative setting, where you will be a lot of people in the room and manage the sedation, just like with a normal induction. Okay, so that was the entire lecture. Thank you so much for watching. If you follow along for this long, please check the references and always check your local guidelines when you're doing these kinds of things. It's still new in Scandinavia and only done in some places, as I'm aware of, but it's going to be more and more of a thing in more and more places. So I hope that you found it useful, and I hope to see you the next time. Thank you so much.